Ini dia adalah gelombang dari irama gambaran EKG dari atrial fibrilasi yang tadi saya sebutkan, di mana iramanya itu tidak teratur. Nah, lalu untuk membedakan adanya heart rate-nya itu, jika heart rate-nya itu kurang dari yang kita sebut dengan slow ventricular response, heart rate-nya kurang dari 60 kali per menit, gitu. Kalau dia normal ventricular response, heart rate-nya itu 60 sampai dengan 100 kali per menit, lalu rapid ventricular response, heart rate-nya lebih dari 100 kali per menit. Gitu. Kunci pada penanganan atrial fibrilasi ataupun atrial flutter itu adalah bagaimana caranya kita mengontrol rate pasien agar dia berada dalam keadaan normal ventricular response. Itu. Ataupun jika dia baru mengalami kejadian atrial fibrilasi atau atrial flutter yang disebut dengan paroxysmal atrial, itu masih bisa ditangani dengan obat-obatan, bisa ditangani dengan ablasi kayak gitu. Sehingga dia dapat menghilangkan atrial atau aritmia atrial yang permanen tersebut kembali menjadi sinus. Gitu. Nah, ini adalah atrial flutter sama tadi ya, ada tingkatannya yaitu normal, slow, normal ataupun rapid. Gambarannya ritmenya bisa teratur atau tidak teratur tergantung dari gelombang P yang muncul tadi. Gitu. Nah, atrial fibrilasi atau aritmia atrial, baik atrial fibrilasi ataupun atrial flutter, itu adalah basic ritmenya atau irama dasarnya. Nah, kejadian irama dasar ini bisa juga mengakibatkan terjadinya gangguan-gangguan yang lain. Contoh pada gambaran EKG 12 lead di sini, kita bisa melihat adanya LBBB. Jadi atrial fibrilasi dengan LBBB, left bundle branch block, gitu. Terus kita juga bisa melihat nih, adanya apa? Adanya akut miokard infark, yaitu terjadinya ST depresi di V4 sampai dengan V6, lalu juga bisa dilihat V1 dan V2-nya. Lead 1 dan lead 2 juga di AVL-nya. Seperti itu. Sehingga apapun irama dasarnya sama dengan sinus gitu kan, gangguan atrial itu atau aritmia atrial itu bisa juga disertai dengan akut miokard infark, terus habis itu gangguan irama prematur ventricle kontraksi atau ventricle extrasystole itu juga bisa gitu, atau hipertrofi itu juga bisa muncul. Kenapa? Karena dia hanya irama dasar, bukan menunjukkan ke semuanya gitu. Oke, nah ini dia atrial fibrilasi atau atrial flutter ini ya, itu untuk dalam pengelompokan heart rate memiliki 3 kriteria yang tadi saya sebutkan, bahwa yang pertama adalah rapid ventricular response, heart rate-nya lebih dari 100 kali per menit, lalu normal ventricular response 60 sampai 100 kali per menit, dan slow ventricular response yaitu kurang dari 60 kali per menit. Nah, keadaan atrial fibrilasi ini itu lebih mengkhawatirkan dibanding dengan atrial flutter. Kenapa? Dalam kondisi atrial fibrilasi, pasti iramanya itu tidak teratur, yang menyebabkan kelainan pada katup dan menyebabkan terjadinya clotting atau sumbatan di pembuluh darah. Akibat clot itu akan lepas ke bagian otak dibandingkan dengan atrial flutter atau gangguan irama yang lainnya. Sehingga dalam tata laksananya itu di guideline, baik guideline dari ESC, mau guideline dari AH, maupun guideline dari Indonesia itu adalah PERKI, Persatuan Ikatan Kardiologi Indonesia, kita tetap harus menghitung, yaitu adalah SAVAS dan Hasbet score untuk menurunkan kejadian stroke akibat karena atrial fibrilasi. Yang sebenarnya teman-teman juga sudah bisa menghitung sendiri, hitungannya gampang. Dia ada nggak masalah dari gagal jantung atau LV disfungsi, bisa dilihat dari pergerakan hasil ekokardiografinya, kemampuan otot jantungnya bagaimana, ejection fraction-nya bagaimana. Kalau ada, skornya 1. Lalu ada nggak riwayat hipertensi? Kalau ada, skornya 1. Lalu usianya lebih dari 75 tahun atau tidak? Skornya 2. Ada riwayat DM nggak? Skornya 1. Gitu. Dari skor 111 ini dan yang sebagainya kalau memang teman-teman bingung gitu kan, ada yang lebih gampang, yaitu dia adalah laki-laki atau perempuan. Kalau mengkajinya kelamaan, kita lihat laki-laki atau perempuan. Laki-laki atau perempuan itu sudah mengkategorikan skornya 1 jika dia memiliki jenis kelaminnya perempuan. Gitu. Ya. Dari skor ini nanti kita akan lihat bagaimana algoritmanya. Nah, sedangkan untuk Hasblad sama, dia dihipertensi nggak, terkontrol atau tidak, gitu. Lalu ada gangguan dari fungsi hati, terus ada fungsi dari gangguan dari fungsi ginjal, gitu. Terus ada riwayat stroke atau tidak, kayak gitu. Lalu dia apa namanya? Kalau memang ada hasil INR, hasil labnya, lalu ada perdarahan atau tidak, lalu usia. Paling gampang di usia untuk Hasblat. Gitu. Nah, mereka memiliki skor maksimum 9, tetapi kita nggak perlu mencari 9-9-nya ini. Gitu. Ya. Dalam algoritmanya, kalau memang ditemukan nilainya lebih dari 2, maka bisa untuk kita ingatkan ke dokter, ya, dokter DPJP ataupun dokter jaga untuk pemberian pengencer darah. Bisa dengan warfarin atau new antikoagulan yang baru. Seperti itu. Yang disebut dengan NOAC. Itu ya. Tetapi kita juga harus kontrol nih. Hasil INR-nya berapa. Untuk apa? Untuk mengurangi resiko terjadi perdarahan. Nah, prosesnya sama seperti ini. Tadi di video, teman-teman bisa lihat. Kalau memang nanti ada terjadi tiba-tiba clotting, lepas, nanti masuk ke otak jadi stroke. Nah, ini salah satu trombusnya. Hanya sekecil ini yang lepas sampai ke otak. Makanya dalam proses pelayanan program pemerintah yang baru dan PBJS menekankan yaitu adalah KJSU KIA, salah satunya adalah stroke. Untuk apa? Untuk menurunkan terjadinya stroke iskemik yang dapat nanti menurunkan angka mortalitas untuk pasien-pasien dan meningkatkan produktivitas untuk pasien-pasien usia muda. Jadi segini nih, kalau teman-teman ngelihat ada stolsel di selang infus gitu kan, akibat karena ada darah yang naik terus jadi stolsel di situ, nah itu lebih kecil, sumbatnya lebih kecil. Ini saat dulu saya pertama kali melakukan pelatihan gitu kan, terus ada clotting gitu kan, ada aktivasi konstruk, di situ onsetnya kurang dari 6 jam. Nah, langsung dilakukan untuk trombektomi, ya kan, stenting, dan kita berhasil mengambil clotting atau trombusnya itu, kita ambil, kita aspirasi, segini nih, kecil itu aja dia langsung jadi stroke. Saat itu diambil, maka langsung ekstremitasnya gerak semua. Yang tadinya hemiparase langsung mengangkat, itu, dan subatenya hanya sekecil itu, trombusnya. Ya, sehingga perlu diperhatikan bahwa teman-teman kalau memang merasakan ada keluhan kayak berdebar, atau yang disebut dengan palpitasi, terus teman-teman tenaga kesehatan, maka cek nadi pasiennya. Kalaupun teman-teman bukan tenaga kesehatan, maka teman-teman juga bisa mengajarkan untuk cek nadi, yaitu dengan paling gampang, yaitu cek di pergelangan tangannya, rasakan ondulasinya, atau paling gampang juga di bagian leher itu lebih kenceng. Rasakan, teratur nggak iramanya? Duk, 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 duk gitu. Atau berdebar nggak? Kalau memang berdebar, maka lakukan pemeriksaan EKG. Tapi yang lebih bagus untuk mengetahui itu kita bisa lakukan EKG 24 jam. Gitu ya. Nah, melakukan EKG sekarang lebih simpel daripada dulu. Kita bisa juga ada smartwatch yang sudah bisa ada EKG-nya. Salah satunya merek-merek yang tertentu gitu, bukan promosi ya. Itu dia sudah bisa menampilkan irama jantungnya. Gitu, dan banyak penelitian-penelitian bahwa salah satu hal yang bisa membuat atau membantu untuk melakukan pemeriksaan pada deteksi untuk kelainan jantung itu bisa menggunakan ini gitu kan. Lalu juga bisa melakukan ambulatory ECG monitoring atau yang disebut dengan Holter monitoring, dan dia bisa dipakai sampai dengan 24 jam atau lebih dari 24 jam gitu ya. Nah, ini adalah tipe-tipe dari ambulatory monitoring. Ada Holter monitoring bisa 24 jam sampai dengan 48 jam. Lalu ada external loop recorder ya, dia bisa 1 minggu gitu, atau bisa implan, bisa sampai dengan setahun atau 2 tahun gitu. Nah, ini adalah salah satu contoh alatnya. Ini adalah hasilnya. Teman-teman bisa lihat di sini. Ini udah saya tandain kuning-kuning, ini adalah PAC, prematur atrial kontraksi. Dari PAC inilah nanti bisa menyebabkan terjadinya atrial fibrilasi. Gitu. Jadi dasarnya pertama ngerasa nggak nyaman di dadanya. Kayak ada yang loncat-loncat, ternyata nggak cuman VES atau ventricle extrasystole atau premator kontraksi PVC. Ternyata juga ada yang lain. Nah, prematur atrial kontraksi ini adalah awal atriumnya itu memberikan impuls listrik. Kalau memang dibiarkan, dia akan mengakibatkan terjadinya aritmia atrial. Gitu. Nah, ini adalah salah satu tambahan, yaitu adalah untuk teman-teman mengenali adanya kelainan bawaan dari lahir. Gitu. Ya, jadi ada aritmia yang dia memuncul dari lahir. Gitu. Baik yang disebut dengan AVNRT ataupun AVRT. Gitu. Nah, hal ini bisa menyebabkan takikardia. Gitu. Jadi pasien itu bisa terus-terusan dia menjadi takikardi saat usianya nanti tertentu. Saya menemukan usia pasien yang dia ada terdapat aksesori pathway atau jalur tambahan atau yang disebut dengan JARAS di usia 16 sampai 17 tahun itu. Saya menemukan beberapa pasien dua itu dia baru muncul nih takikardinya. Jadi dia sering takikardi padahal di usia mudanya dia nggak ada masalah gitu. Nah, dari proses fisiologinya sebenarnya normalnya kan seperti ini. SA node memberikan ke AV node, AV node ke Purkinje gitu. Tetapi di sini SA node memberikan ke AV node, lalu dia balik lagi dari ventricle yang harusnya sudah selesai, stop, dia masuk lagi nih ke AV node lagi. Jadi double. Gitu. Nah, hal diperbesar kita bisa melihat di sini. Kan harusnya bentuknya adalah lubang P, Q, R, S gitu kan. Nah, di sini adanya lengkungan yang disebut dengan delta wave. Gitu. Nah, lengkungan ini nih. Kelainan ini disebut dengan WPW, Wolff Parkinson White Syndrome. Yang kalau memang sudah ada, maka nanti dia harus dilakukan electrophysiology study. Kalau memang sudah ketemu, nanti yang membuat aksesori pathway-nya atau tadi jarak itu dilakukan ablasi dan hasilnya akan kembali jadi normal. Kalau enggak, nanti dia akan sering berdebar, terus tiba-tiba merasakan terjadinya supraventricular tachycardy ataupun ventricular tachycardy yang harus dilakukan kardioversi. Itu. Nah, sedangkan AVNRT itu bisa karena masalah-masalah yang gangguan impulsnya mengakibatkan ada di perputaran jarum cepat yang ada di AV node. Gitu. Salah satunya adalah SVT, supraventricular tachycardy, yang teman-teman mesti di UGD sering mengetahui ada pasien tiba-tiba berdebar, habis itu hilang, berdebar, hilang gitu. Setelah diketahui bahwa oh dia sering nih heart rate-nya lebih dari 150 kali per menit. Dikasih obat-obatan, protokol-protokol baik obat-obatan farmakologi seperti anti aritmia gitu. Terus habis itu diberikan mungkin kardioversi, tapi nanti dia berulang lagi. Nah, di sini maka AV node-nya ini tuh yang tadi dia masuk ke jalur cepat. Jadi itu harus dimatikan. Nah, ini tambahan lagi adalah ventricle tachycardia. Teman-teman sudah tahu pasti QRS-nya lebar dan ventricle tachycardia itu memiliki banyak jenisnya, ya. Dan bisa terjadi tuh kita nggak ada keluhan, kita nggak ada apa-apa, tiba-tiba ngerasa berdebar aja. Pas saat tadi dilakukan Holter monitoring atau EKG 24 jam, terjadilah VT. Saya udah menemukan beberapa pasiennya, terus habis itu kita rujuk untuk dilakukan ablasi. Tapi pasiennya ada keluhan, nggak ada. Dia makan biasa aja. Tetapi hasil recordnya menunjukkan ventricular tachycardia. Tuh. Oke. Nah, ini adalah tata laksananya untuk takikardia, ya. Jadi mau dia AF, mau dia ventricular tachycardia, gitu. Tapi dengan nadi, ataupun mau dia supraventricular tachycardia, yang tadi kita sebutkan AVNRT, ataupun AVRT, maka prinsipnya sama. Kita harus mengikuti alur algoritmanya. Gitu. Ya. Di sini kita menganutnya pada AH 2020, itu yang terbaru setiap 5 tahun, nanti 2026 akan muncul lagi gitu. Nah, kita harus kaji dulu nih, pada pasien tersebut HRT lebih dari 150 atau tidak, lalu kita bisa lakukan pemberian oksigen gitu kan, terus habis itu kita bisa melakukan monitoring untuk kardiaknya gitu, baik tensi, terus oksigenasi, pulse oximetry, terus heart rate-nya gitu kan, lalu pemasangan intravena dan EKG 12 lead untuk mengetahui gitu. Terus kita lihat nih apakah terjadi tanda-tanda yang mengakibatkan kegawatan. Kalau memang tidak ada, maka kita bisa lakukan observasi, tapi kalau memang ada, maka kita bisa melakukan tergantung nih apakah kita langsung mau kasih dengan obat-obatan ataupun kardioversi tergantung dari uh, teman sejawat kita, yaitu adalah dokter umum ataupun dokter spesialis. Tetapi tugas kita sebagai perawat itu harus mengingatkan. Kenapa? Saat keselamatan pasien itu tergantung dari tim, bukan dari personal. Seperti itu. Contohnya saat code blue. Code blue itu belum tentu semua orang di sana tidak panik. Itu yang pertama. Kedua, belum tentu semua orang di sana mengerti terkait tata laksananya atau sering mengikuti advance cardiac life support gitu. Ya. Nah, untuk itu tugas tim itu adalah mengingatkan leader. Untuk pengobatan, obat-obatan, terapi listrik itu memang miliknya dari dokter spesialis. Tetapi dokter spesialis ataupun dokter umum. Tetapi untuk mengingatkan kita wajib. Salah satunya adalah AED contoh. Kalau kita bisa melihat itu iramanya adalah VT dan kita yakin VT, ya sudah, kita bisa lakukan terapi listrik untuk mempercepat. Makanya dibunyikan di SOP rumah sakitnya masing-masing. Kalau kita menunggu adanya dokter umum yang harus datang gitu untuk melakukan terapi listrik, maka VT ini akan menjadi asistol. Risiko kematiannya lebih tinggi. Kalaupun di rumah sakit ada AED, kita bisa pakai AED karena kenapa? AED itu bisa langsung memerintahkan. Gitu. Ya, AED aja bisa. Kenapa kita manusia gitu yang bisa belajar, kita tidak bisa mengerti hal ini. Gitu. Nah, sebenarnya banyak yang menjadi perdebatan. Apakah perawat boleh melakukan defibrilasi tanpa pendampingan atau delegasi atau tidak? Sebenarnya itu bisa dibunyikan di SOP masing-masing rumah sakit. Kenapa? Di dalam aturan bahwa kasus emergensi tenaga terlatih dan tersertifikasi boleh melakukan. Tuh. Oke ya. Saya tidak akan membahas ini lebih dalam. Ini adalah ventricular fibrillasi ya. QRS-nya lebar, iramanya tidak teratur, dan penanganan terjadinya cardiac arrest itu bisa kita lihat juga pada keadaan guideline di AH 2020 yang sama tadi juga membutuhkan terapi listrik dan terapi obat-obatan gitu. Nah, satu lagi yang diamati ke saya yaitu ada terkait hipertrofi. Nah, hipertrofi itu teman-teman pasti sudah tahu adanya pembesaran di dalam ruang otot jantung seperti itu. Nah, hipertrofi itu ada hipertrofi atrial atau atrium dan hipertrofi dari ventricle. Nah, normalnya adalah seperti ini. Nah, ini adalah yang mengakibatkan terjadi hipertrofi. Otot-otot jantung ini contohnya di ventricle, otot-otot jantungnya normal. Tetapi di sini adalah menebalnya ke dalam. Nah, pada proses penebalan otot jantung yang ke dalam ini, ya, itu sering terjadi pada olahragawan yang terlalu over, berlebih. Sehingga dia mengakibatkan terjadinya henti jantung mendadak saat dia membutuhkan kecukupan dari cardiac output-nya. Saat dia berlari tidak mampu, tiba-tiba dia meninggal. Kenapa? Volume di sini sedikit. Ingat kan rumusnya? Stroke volume, cardiac output itu stroke volume kalikan heart rate. Gitu. Heart rate-nya dipacu. Padahal rata-rata heart rate olahragawan itu pasti di bawah 60. Dipacu lagi makin tinggi tapi volumenya nggak ada. Yang diedarkan juga nggak ada. Maka yang balik lagi ke jantung itu nggak ada dan dia menjadikan pasien itu sering terjadi sudden cardiac death. Gitu. Nah, teman-teman sudah mengetahui bahwa yang dulu kita pelajari ada namanya RAH, right atrium hypertrophy, atau yang sekarang sebut dengan sering didengar ada right atrial enlargement. Gitu. Tandanya adalah adanya gelombang P, ya ini gelombang P itu yang tinggi. Oke ya, ini ada lead 1, ini lead 2 nih, gitu. Ini lead 3. Gelombang yang tinggi. Tingginya berapa? Tingginya lebih dari 3 kotak kecil atau 3 milimeter. Itu ada di lead 2, lead 3, dan AVF. Tuh. Itu menandakan adanya dilatasi atau hipertrofi yang ada di atrium kanan. Sedangkan pada atrium kiri, atau mungkin teman-teman sering mendengar ada LAH dulu, left atrium hypertrophy atau yang sekarang left atrial enlargement, maka dia muncul gambaran seperti P yang berwujud P seperti M, atau P bifasik yang bentuknya seperti huruf S yang dia turun ke bawah di lead 1 dan V1. Itu ya. Jadi teman-teman bisa lihat nih. Masalahnya di mana sih? Rata-rata pada pasien-pasien yang mengalami kejadian-kejadian hipertrofi atrial ini itu pasti memiliki masalah yang ada di paru-paru. Kenapa seperti itu? Karena selain nanti dia membutuhkan supply gitu kan, oksigenasi untuk dia masuk ke paru-paru, di sini ada katup pulmonalis gitu, pasti dia akan memperberat nih di sini nih. Jadi dia memberikan massa yang lebih tinggi, beban kerja di atrium lebih tinggi sehingga dia harus meningkatkan kontraktilitasnya gitu, atau meningkatkan tekanan ruang dari atrium tersebut. Tuh. Oke. Nah, ini adalah gambaran EKG tanda dari hipertrofi dari ventricle, ya, yaitu adalah LVH, left ventricle hypertrophy, ataupun RVH, right ventricle hypertrophy. Yang teman-teman pasti sudah juga tahu di mana pada kasus-kasus LVH, pada kasus LVH ataupun RVH itu bisa didasari dari terjadinya hipertensi yang sangat lama. Tetapi yang tadi disebutkan, bagaimana kalau pada pasien-pasien yang dia olahragawan? Kalau olahragawan, untuk gambaran EKG, jarang sangat kita mengetahui terjadinya hipertrofi pada gambar EKG. Dengan tandanya adalah kalau LVH di V5 atau V6, itu tinggi R-nya ini, ya, itu lebih dari 27, ya, 27 kotak kecil. Oke, ya, atau 27 milimeter. Tuh. Atau juga bisa kita ada lain. Kita bisa juga kalau kita merasa ini tinggi tapi ini nggak terlalu, kita bisa lihat dari V1-nya. V1-nya terlalu dalam nggak gelombang S-nya. Yaitu kita bisa lihat gelombang R di V6 ditambahkan gelombang S di V1. Kalau dia lebih dari 35, maka dia mengalami LVH. Untuk tanda yang lain seperti ST depresi dan sebagainya itu karena prosesnya itu dia memberikan impuls listrik jadi lebih lama gitu. Jadi dia mengikuti morfologinya. Sedangkan ada RVH, adanya gelombang R di V1 dan gelombang S di V6. Prinsipnya simpel, kita tinggal melihat yaitu adalah vektor seperti itu. Ini ada V1, ini ada V6. Di sini gelombang R-nya kecil, harusnya nggak kelihatan. Gelombang S-nya yang tinggi. Sedangkan di V6, gelombang R-nya yang tinggi dan gelombang S-nya yang kecil. Prinsipnya seperti itu untuk melihat RVH. Tetapi bagaimana tadi pada atlet? Nah, teman-teman bisa melihat di sini. Ini kalau kita melihat ada pemeriksaan rongsen yaitu kardiomegali. Nah, kardiomegali itu salah satunya adalah apa? Salah satunya itu bisa terjadi hipertrofi. Tetapi bisa curiga yang lain. Curiganya apa? Bisa karena ada cairan di jantungnya. Jadi nggak pembesaran aja, bisa karena cairan, cairan itu bisa karena macam-macam gitu. Ada darah di otot perikardnya, ya kan di perikardnya gitu kan, atau ada masalah-masalah yang lain, tumor dan sebagainya gitu. Nah, sedangkan untuk melihat lebih jelas itu pada di gambaran ekokardiografi ini dia. Jantungnya membesar. Dan kita bisa melihat pergerakannya sudah tidak normal. Dan nanti kita lihat kemampuannya EF-nya berapa. Begitu juga pada atrium. Nah, sedangkan pada atlet itu membesarnya itu ke dalam. Jadi tidak jarang sekali dilihat dia mengalami kardiomegali. Tetapi pada gambaran dari hasil ekokardiografinya di sini lebih ke dalam gini. Gitu. Atau yang disebut dengan HOCM singkatannya. Itu. Oke. Terima kasih atas perhatiannya. Wassalamualaikum warahmatullahi wabarakatuh. Saya kembalikan ke Nas Faisal.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Nurse Yusuf Duyanto atas pemaparan materi yang sangat luar biasa. Kita berikan aplaus terlebih dahulu kepada pemateri kedua kita. Baiklah, Nurse Yusuf, kita akan masuk kepada sesi Q&A atau sesi tanya jawab. Ya, di sini kembali saya tawarkan kepada teman-teman semua. Apabila ada yang ingin bertanya langsung kepada pemateri kita, bisa menggunakan fitur raise hand yang ada di fitur reaction di bawah. Silahkan. Apakah ada yang ingin bertanya secara langsung kepada pemateri kedua kita? Ya. Sejauh ini belum ada yang raise hand nih, Nurse Yusuf.
Ya,
Jadi
di kolom chat
kita
banyak
akan,
kelihatannya.
ya, makanya kita mungkin akan kita jawab pertanyaan-pertanyaan yang langsung diajukan di kolom chat saja ya, Nurse Yusuf ya. Baiklah, kita mulai dari pertanyaan pertama, yaitu pertanyaan dari atas nama pemilik akun Rukialun dari Bekasi Kota. Izin bertanya Pak, kalau SVT tadi kan heart rate-nya lebih dari 150. Kalau atrial fibrilasi dan atrial flutter, heart rate-nya bagaimana? Dan
Yes.
ini di sini dia ngasih pertanyaan tambahan, sepertinya bisa langsung kita satukan saja ya Narsisup ya.
Ya, ya. Ah.
Pada kasus atrial fibrilasi, selain risiko clotting dan terjadi stroke, apakah bisa beresiko terhadap organ lain, misal trombus pada jantung itu sendiri atau di ginjal? Ya, cukup jelas pertanyaannya, Nurse Yusuf?
Cukup sambil saya baca ya di kolom chatnya
Oke,
takut lupa. Oke,
baik.
yang pertama
Silakan
ya,
dijawab.
terima kasih untuk Nas. Ini ibu aja deh saya panggil, Ibu Rukialun, gitu kan. Saya takutnya bukan perawat nanti, bisa juga dokter, gitu kan. Jadi Ibu Rukialun, terima kasih pertanyaannya. Pada kasus-kasus yang tadi saya sebutkan, untuk SVT dan atrial gitu, itu tergantung dari basic ya irama dasarnya apa nih? Kalau kita sering bilangnya adalah iramanya bagaimana sih gitu. Teratur atau tidak teratur. Kalau pada kasus SVT supraventricular tachycardia itu jarak R ke R-nya atau iramanya pasti teratur gitu. Nah, sedangkan pada gambaran yaitu adalah atrial, kelainan aritmia atrial, iramanya itu tidak teratur atau bisa teratur jika dia atrial flutter. Kriterianya kayak gitu. Dan memiliki gelombang P yang lebih dari satu. Ya. Nah, tetapi ada tapinya nih. Untuk tata laksananya, makanya tadi saya tambahkan untuk tata laksananya itu langsung mengacu pada takikardia alogaritma. Gitu. Maksudnya takikardia alogaritma bagaimana? Asalkan QRS-nya itu sempit, itu tata laksananya sama. Kalau QRS-nya itu lebar, berarti tata laksananya kita ikut QRS lebar, yaitu adalah ventricle gitu. Jadi kalau QRS-nya sempit, ya mau dia teratur tidak teratur, iramanya kita bisa nih lakukan sama gitu. Kita bisa memberikan obat-obatan yaitu adalah tadi ada adenosin trifosfat, ada yaitu penggunaan amiodaron itu. Tetapi yang kita bisa lihat yaitu adalah ada nih atrial fibrilasi yang heart rate-nya kurang dari 150, contoh 100 sampai dengan 140 atau 49, anggap gitu kan. Nah, kita bisa nih lihat apakah dia AF lama atau tidak. Kalau memang kita yakin dia AF lama, mungkin dokter akan memberikan digitalisasi gitu, sehingga untuk mengontrol rate-nya. Tetapi ada juga kalau konsul ke spesialis karena dia tidak ada recordnya gitu kan, tidak ada record-recordnya yang sebelumnya juga dan pasiennya itu tidak ada yang hipotensi, tidak ada gelisah dan sebagainya, maka ada juga yang memberikan obat anti aritmia kelas 3 yaitu adalah amiodaron. Diharapkan kenapa? Dia bisa balik kembali jadi sinus. Karena tadi paroksimal atrial fibrilasi atau paroksimal atrial flutter. Seperti itu. Jadi dia menghambat untuk menyebabkan terjadinya aritmia yang berkepanjangan. Seperti itu. Itu untuk pertanyaan yang pertama. Sehingga kita harus tahu dulu nih, dia ada gelombang P atau tidak, irama teratur atau tidak, seperti itu. Sehingga kita bisa menentukan apa sih irama dasarnya, supraventricular tachycardia ataupun atrial kah. Karena kalau dia sinus, ya sinus tachycardia juga sama kan seperti SVT gitu. Teratur tapi heart rate-nya kurang dari 150 gitu. Makanya dalam guideline AHA dia menyamakan tergantung dari bentuk QRS-nya. Tidak teratur ataupun teratur. Bedanya hanya nanti pada setting untuk penanganan dari kardioversinya. Ya, jumlah joule-nya berapa, untuk pasien dengan iramanya teratur, yaitu adalah SVT, ya, ataupun pada irama yang dia atrial fibrilasi atau tidak teratur. Jumlah joule-nya berapa dan bagaimana settingannya, sinkronis ataupun asinkronis. Nah, Untuk pertanyaan kedua, pada kasus atrial fibrilasi, selain berisiko clotting dan terjadinya stroke, apakah bisa terjadi pada organ lain, misalnya trombus di jantung atau di ginjal? Sangat bisa, tidak menutup kemungkinan, sangat bisa. Makanya tadi saya bilang bahwa kalau dia lepasnya trombusnya ke otak, ya, jadi masuk ke aorta lewat nanti left common carotid, terus masuk ke dalam pembuluh darah otak, gitu kan? Dia nanti akan jadinya stroke. Kalau memang dia lepasnya ke brachiocephalika, ya, terus habis itu masuk ke ataupun dia lepas dari aorta ke aorta descendens, masuk ke iliaka externa, jadinya ali, gitu. Jadi masuk ke ginjal bagaimana? Bisa, bisa. Tetapi ya trombus itu pastikan berjalan karena ada tekanan aliran darah yang tekanannya tinggi. Sehingga untuk masuk ke jantung itu sendiri yang nanti jantung itu akan dialiri darah jika terjadi darah balik dari fase diastolik, ya kan, nanti masuk ke sinus coronarius, itu kan darahnya sedikit, jadi tekanannya juga pasti akan lebih kecil seperti itu, sehingga itu jarang terjadi, tetapi bisa-bisa. Bagaimana ke ginjal? Itu juga bisa saat nanti jatuh ke descendant terus masuk ke arteri, contoh ada arteri renalis, arteri mesenterika, ke lambung, kemana dan sebagainya, itu juga bisa. Tetapi pasti dia akan lebih cepat jatuhnya pada bagian yang paling bawah. Seperti itu. Terima kasih.
Baik, terima kasih banyak Nurse Yusuf atas jawabannya yang sangat luar biasa. Kita berikan aplaus terlebih dahulu. Sekali lagi saya ucapkan terima kasih banyak kepada Nurse Yusuf atas penjelasannya, dan saya juga ucapkan terima kasih kepada Kak Rukia Lun yang sudah turut aktif dalam sesi Q&A kita pada pagi hari ini. Baiklah, oke. Nurse Yusuf, ini kita sudah ada pertanyaan tambahan lagi yang kedua dari pemilik akun atas nama Muhammad Ulil Amri. Izin bertanya, bagaimana membedakan atrial takikardi dan SVT? Kapan disebut sebagai atrial takikardi dan kapan disebut sebagai SVT? Karena kalau dilihat dari heart rate sama-sama di atas 150. Terima kasih. Sudah jelas pertanyaannya, Nurse Yusuf?
Sudah. Terima
Ya,
kasih.
silakan dijawab.
Oke, untuk atrial takikardi dan SVT sebenarnya awal mula dari penyebutan ini dulu di tahun berapa saya lupa, pernah baca itu di guideline-nya ESC sama di jurnalnya AHA bahwa itu sebenarnya sama seperti itu, gitu ya. Nah, dibedakan, ya kan, dibedakan itu karena kenapa disebut sama dulu nih? Kenapa disebut sama? Karena dia ada di bagian atas, di bagian atas dari ventricle. Jadi perbatasan itu adalah katup atrioventricular, gitu kan. Nah, itu di bagian atas. Nah, makanya disebut dengan supraventricular tachycardia semuanya. Tetapi setelah dilihat ada tuh alat-alat seperti elektrofisiologi dan sebagainya, muncullah penelitian-penelitian gitu. Makanya dibedakan. Kenapa? Pada atrial tachycardia itu dia akan muncul gelombang P yang bisa numpuk dengan QRS gitu. Dan mempengaruhi juga bisa terjadi mempengaruhi terjadi ketidakteraturan atau irregular pada jarak antara R ke R. Sedangkan pada supraventricular tachycardia ya dia hanya nanti masuk ke jalur cepat pada AV node. Yang tadi saya jelasin ya kan, gambaran ada plus ada min gitu, itu masuk ke jalur cepatnya. Sehingga impuls listriknya hanya berputar-putar terus ke jalur cepat, tidak dibagi ke jadi jalur lambat gitu. Sehingga pasti jaraknya akan sama dan tidak ditemukan P atau P-nya menuntuk ke T karena dia terlalu cepatnya gitu. Tetapi gambarannya iramanya teratur. Bagaimana membedakannya? Nah, membedakannya itu kita bisa lihat gitu. Bisa lihat dari mana? Kita bisa lihat dari iramanya. Makanya pertama yang harus dilihat adalah kalau untuk membedakan SVT ataupun atrial itu kita lihat dari iramanya gitu. Sehingga untuk atrial takikardi itu sekarang sering disebutnya adalah yaitu atrial fibrilasi atau atrial flutter rapid ventricular response gitu. Karena untuk membedakan QRS-nya itu satu, ya responnya satu, tetapi rapid pada keadaan gelombang P-nya. Seperti itu. Oke, terima kasih. Silakan kalau ada yang lain.
Baik, terima kasih banyak Nurse Yusuf atas jawabannya yang sangat luar biasa. Kita berikan aplaus terlebih dahulu, ya. Dan saya ucapkan terima kasih juga kepada Muhammad Ulil Amri, ya, atas keaktifannya dalam sesi tanya jawab ini. Dan saya ucapkan terima kasih juga untuk seluruh peserta yang lain yang masih antusias menyimak seminar kita dari awal mulai hingga sekarang sudah hampir menjelang siang, ya. Baik, sebelum kita lanjut, saya masih menawarkan kepada teman-teman apakah masih ada yang ingin bertanya kepada pemateri kita. Saya masih mempersilahkan untuk teman-teman yang ingin bertanya langsung kepada pemateri kita bisa menggunakan fitur raise hand-nya. Nanti untuk akses mikrofon akan kami buka. Ya, atau mungkin bagi yang mungkin mikrofonnya sedang tidak bisa diakses, bisa mengetik pertanyaannya di kolom chat. Ya. Kita masih beri kesempatan buat teman-teman semua. Ya, Nurse Yusuf, sepertinya memang sudah tidak ada pertanyaan lagi nih untuk sesi materi yang seminar kita yang kedua ini. Baik, saya ucapkan terima kasih banyak kepada Nurse Yusuf Dwianto atas sharing ilmunya yang sangat luar biasa. Ya, sekali lagi kita berikan aplaus kepada pemateri kita yang kedua, kepada Nurse Yusuf Dwianto. Namun sebelum kita lanjut kepada sesi seminar yang ketiga, saya akan mempersilahkan Nurse Yusuf untuk bisa memberikan kata-kata penutup sebelum nanti akan kita lanjutkan kepada sesi seminar yang ketiga. Silakan Nurse Yusuf.
Oke, terima kasih. Sebenarnya ini bukan kata-kata penutup, tetapi mungkin sebagai share pengalaman aja ke teman-teman semuanya bahwa sering sekarang terjadi pasien henti jantung tiba-tiba di usia muda. Ya, bahkan sekarang banyak sering terjadi pasien yang mengalami henti jantung yang dia sedang berolahraga. Untuk itu, teman-teman di masa sekarang lebih baik untuk melakukan pemeriksaan kesehatan terkait jantung teman-teman untuk dapat menurunkan angka kejadian sudden cardiac death. Seperti itu. Karena pada kasus-kasus juga, pada pasien-pasien yang mengalami aritmia, itu jarang terdeteksi dari awal. Saat terdeteksi, dia sudah mengalami kelainan-kelainan yang lain atau mengalami hal-hal yang sudah tidak dapat ditangani. Seperti itu. Sehingga perlu dilakukan mulai dari saat ini untuk teman-teman agar teman-teman juga dapat menjaga kualitas hidupnya. Seperti itu, terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Nurse Yusuf Dwianto atas pemaparan materi yang sangat luar biasa. Sekali lagi kita berikan aplaus kepada pemateri kedua kita. Ya, saya ucapkan terima kasih juga kepada seluruh peserta yang masih turut aktif dalam sesi tanya jawab kita dari awal sesi pertama hingga sesi kedua ini. Ya, saya mengapresiasi yang sangat luar biasa kepada seluruh peserta semua. Baiklah, namun sebelum kita beralih kepada sesi seminar yang ketiga, sebelum kita masuk kepada sesi seminar yang ketiga, ya saya akan menginfokan karena memang untuk yang sesi seminar berikutnya adalah pembicara kita adalah pembicara internasional, maka untuk sesi berikutnya kita akan menggunakan bilingual, yaitu menggunakan bahasa Inggris dan juga bahasa Indonesia. Dan saya akan menginformasikan kepada seluruh peserta bahwa apabila pada saat teman-teman ingin bertanya, namun mungkin tidak terlalu pede dengan bahasa Inggrisnya, teman-teman boleh nanti pertanyaannya ketik di room chat yang ada di Zoom meeting kita ini. Nanti akan kita bantu untuk kita terjemahkan ke dalam bahasa Inggris dan akan kita tanyakan kepada pemateri kita. Baiklah, kita akan lanjut untuk sesi seminar yang berikutnya di sesi yang ketiga. But before we begin, I would like to express our gratitude to our keynote speakers, Associate Professor Dr. Muhammad Said bin Nurul Mal and Mr. Winit Longlaren, MSc, for taking the time to share their expertise with us. But before we started the seminar, I would like to introduce our keynote speakers. The third keynote speakers is Associate Professor Dr. Muhammad Said bin Nurul Mal. And please let me to share the curriculum vitae of our keynote speakers. Ya. Untuk berikutnya kita akan kedatangan tamu yang sangat istimewa, pembicara yang sangat istimewa, yaitu adalah Associate Profesor Dr. Muhammad Said bin Nurul Mal. Ya, namun sebelum kita memulai pada sesi seminar bersama Dr. Muhammad Said, izinkan saya untuk men-share CV dari pembicara ketiga kita. Ya, baik. Untuk pembicara ketiga kita di sini, our third keynote speakers is Associate Professor Dr. Muhammad Said bin Nurul Mal. And now, Professor Said was researcher and also the lecturer in nursing at Kuliah of Nursing in International Islamic University of Malaysia. And he is the associate professor for a Kuliah of Nursing in International Islamic University of Malaysia. Oke. Pembicara ketiga kita hari ini beliau adalah Associate Professor Dr. Muhammad Said bin Nurul Mal. Beliau saat ini aktif sebagai dosen dan juga researcher di Kuliah of Nursing International Islamic University di Malaysia. Oke, ini merupakan pengalaman dan juga background beliau buat teman-teman semua peserta seminar yang mungkin penasaran dengan background beliau. Beliau merupakan lulusan dari program PhD in Nursing in Emergency and Trauma Nursing, Doctor of Philosophy di Chiang Mai University of Thailand pada tahun 2014. Dan beliau juga pernah menempuh pendidikan di Bachelor of Nursing Studies di Dublin City University of Ireland di tahun 2005. Oke. Untuk riwayat pekerjaan beliau dan juga riwayat seluruh pelatihan beliau bisa teman-teman lihat di screen yang saat ini sedang saya bagikan di layar. Banyak sekali memang pengalaman dalam researcher dan lain-lain. Ya, bisa teman-teman lihat semua di sini. Oke. Baiklah. Kita masih menunggu Profesor Said untuk bergabung. Mohon ditunggu sebentar karena kita masih ada sedikit terkendala terkait signal di sini. Jadi Dr. Said sedang berusaha untuk bergabung bersama kita. Kita akan tunggu untuk sebentar. Dan saya ingin mengingatkan kepada seluruh teman-teman semua bahwa Cito Organizer selain dari memberikan seminar, kami juga akan memberikan door prize kepada teman-teman semua, di mana door prize tersebut akan kita bagikan kepada peserta teraktif, di mana peserta teraktif akan kita nilai dari keaktifan teman-teman dalam sesi Q&A. Dan door prize-nya berupa saldo e-wallet sejumlah Rp50.000 untuk masing-masing pemenang. Dan jangan lupa untuk teman-teman semua bisa membuka akun Instagram dari @citoorganizer, di mana di akun Instagram ini teman-teman bisa mendapatkan info terkait seminar-seminar lanjutan dari Cito Organizer dan juga pelatihan-pelatihan yang akan Cito Organizer lakukan di ke depannya selama setahun ke depan ya. Dan juga buat teman-teman yang mungkin tadi joinnya telat di sesi seminar kita kali ini, teman-teman tidak usah khawatir karena Cito Organizer juga memiliki akun YouTube di mana setiap seminar kita, bukan hanya seminar hari ini tapi seminar-seminar sebelumnya, kita siarkan secara langsung di YouTube dan semua terekam di channel YouTube @Cito Organizer. Jadi teman-teman bisa cek di sana untuk bisa mereview kembali materi-materi yang sudah kita jalankan di setiap seminar yang Cito Organizer lakukan. Baiklah, oke. Profesor Said sudah join bersama kita. Kita sapa terlebih dahulu. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Profesor Said. Oke.
Okay. Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Faisal. How are you? I'm doing very good here.
Oh my God. It's really nice to see you. And this is really exciting because finally we meet again in this
Yeah,
our
for quite some
international
time.
event webinar. Alhamdulillah.
Alhamdulillah.
Okay. Okay, Professor Said. So I already show your curriculum vitae. So without any further ado, please joining me to exciting this moment to our keynote speaker, Professor Associate Professor Dr. Muhammad Said bin Nurul Mal. Please giving a round of applause for our keynote speakers and Professor Said. So the time is yours.
Okay, thank you very much. Okay, are you allowed me to share my slides?
Of course, we already have the slides. So, do you want to share by your own device?
I would like to share. Can I share the slides? It's much easier for me to control.
Okay. Please be my guest.
Okay. Okay. One second. I open first my.
It's okay. Just taking your time.
Okay. How many minutes you are giving me for my presentation, Faisal?
You have 16 minutes.
Okay.
1
brilliant.
hour. 1
Okay,
hour for the
okay.
presentation.
Okay, brilliant, brilliant. So I need to now, here we go. Share. Can you see my slide now?
Okay.
Is
The
it full
slide is
screen?
clear on the screen, so you
Okay.
can go on your presentations.
Thank you very much, Faisal. Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh, and a very good morning. Happy Sundays to everyone. Okay, and I would like to congratulate Cito and organizer for making this such international webinar more outstanding for nurses in Indonesia to continue provide a professional development opportunity to them. Today, my topic here on interpretations of 12-lead ECG. I think we will straight go to the specific on the topic. Then you will understand more on my presentations. Why it's not moving? Okay. So the topic given to me specifically is about 12-lead ECG for several diseases that occur in coronary systems, which is acute myocardial infarct, supraventricular tachycardia, ventricular tachycardia, and heart failure. Do not worry, I will try to simplify these to make you an understanding. Okay, so in this webinar, learner will basically, because you need to know the coronary disease, but you cannot miss the ECG. So you need also understand the electrical conductive system. The conductive system then will give you better understanding than how we interpret by the 12-lead ECG. Then we know what is a normal ECG, is a sinus rhythms, okay, and then the ECG rhythms in ischemia, in AMI, in supraventricular tachycardia, and ventricular tachycardia. What are these two different things? And common ECG rhythm in heart failure. So these are the kind of things today session will give you a better understanding, inshallah. Okay, so when we talk about all this abnormality happen in ECG, you need to know about the normal rate, how to calculate the interval of QRS, how to interpret the strips, and differentiate between the normal and abnormal. Of course, the normal is sinus rhythm. Okay, um, uh, before we go further, I would like to cover about 5 to 10, not more than 10 minutes, basically in understanding how this works, okay? You need to know the reading skill of the ECG has to be very, very detailed, precise, because I think you know what I'm referring here, the grid, right? So we will talk all these things. So the grid then will give you an understanding of the rate, rhythm, interval, and the axis of the QRS. Okay, the morphology changes then happen. The problem, the morphology, will then cause the conduction abnormality. Okay, when you have a conduction, then you have the arterial abnormality, ventricular hypertrophy, ST changes, and the ischemia and infarction. And those are the causes of abnormal reading. So, ECG is a method of measuring, displaying, and recording the electrical activity of the heart. Okay, so what does it work? It has the pacemaker word that we use. Electrical stimuli is amplified to create a rhythm stream. I'm not going to talk about uh, very, very detailed, but I would like to tell you that every S T, QRS, and P, it all has a very important electrical stimuli to bring the rhythm stream on the functional of your heart or the condition of your heart. So consistently, the machine will then produce representations of the heart electrical activity. So, I before we go on the some history, I just want to inform you that in this modern era, we have an AI function, or most of the hospitals, they already have an ECG where they can do the interpretation. But why do we still need to learn about ECG? I will make you a better understanding of it. Okay, let's say when we drive our car, we on the Waze. Waze is an example of AI. Okay, Waze is an example of AI, but will you follow exactly what the way say when you have a suspicious? For example, you drive, then you see beach in front. Will you continue your car to the beach? No, right? You will reverse and you will reset. The same thing how AI works, in the natures of ECG machines. Well, okay? You know that in the history, first generation, in the world, they use this kind of machines. You can see how complicated, where you put one hands and another legs in the water to give the readings of the patients. Yeah, or by using the salt water. This is how the electric work takes place. But the moderns, it depends where you are, but mostly we have these the big one in the hospitals, and because this is how they go for learning, yeah, and they go for functionals of the ECG. But we also have that actually all these are traveling. Don't get wrong, but you can control either you want lead two or whatever lead you want, but one in the form of the paper and one with long strip, but it has all 12 lead ECG. Okay. Um, the heart electrical conduction system is the primary component of the heart's condition system, including sinusoidal nodes, the natural pacemaker located in the right atriums, initiating the heartbeat. Okay, this is what we call the natural pacemaker. So, what do you mean a pacemaker is stimuli? Yeah, regulating the contraction. That's why uh, you have a device of pacemaker. When your heart are not properly pumping, then we have a Holter, right? A kind of pacemaker to control that. So basically, pacemaker is a condition of regulating contraction. Then we have anteroventricular node located between the atria and the ventricle, slowing the impulse to allow complete atrial contraction and bundle of His, Purkinje fibers. These are also a transmit impulse and network fibers to impulse throughout the ventricular. So the process of depolarization, okay, PQR, depolarize, then repolarization, okay, describing how electrical impulse flow through the conduction system and create an ECG wave. So this is what the process of electric conduction happens. Okay, there's some diagram for you to give a better understanding of how the systems work. If you look on the sinoatrial nodes, then this is what we call atrioventricular nodes. You can see that how it goes by the left bundle branch, right bundle branch, and all the network for the conducting. Yeah. Okay. So as a node initiate electrical impulse that sends the heart rate. So the control. Okay. Remember the pacemaker, they will give you a range. So some of us having range of this heart rate. Am I right? One second. Okay, sorry. Okay, so if you know that you and I could have a rate of pulse rate between 60 to 100. That's what we call normal, okay? Basically 80, 90, right? So this is the one the pacemaker control, stimuli and control construction. So we will have this. So when you have this, you are kind of giving a normal heart rhythm, yeah, normal heart rate. So AV node act as a gatekeeper, delaying the impulse to allow the atria to empty blood into the ventricular fully. So bundle of His is transmit the impulse through the ventricular septum, splitting into two right of left bundle branch and Purkinje fiber contact impulse quickly across the ventricle, resulting synchronized contraction and ventricular muscle. So that's why you can see it's all look same and sinus rhythm. Okay, this is how the function. It is nice to know because then when you talk about ECG, you will understand better. Okay, I think this is how we work out pacemaker of the heart, the dominant pacemaker, 60 to 100. AB node backup pacemaker with an intrinsic rate of 40 to 60 beats. A ventricular cells a backup pacemaker with an intrinsic rate of 20 to 45. This is how AB node and ventricular cell mixed and it becomes total of 60 to 100. This is how the conductive systems work, okay? If you look on the pictures below here, P, QRS, and T, and that's how the rate, heart rates come in the picture. So how electrical impulses trigger coordinated contraction in the heart chamber. So you need to understand this, then we will then go deeper on giving you a better understanding of the P wave, QRS, and T segment by understanding the movement or depolarizations and repolarization, okay? The sequence of excitations, the arterial contractions begin with the SA node impulse, causing arterial depolarization, and contraction pushing blood into the ventricle. So ventricular filling the AV node delay allows time for the ventricle to fill with the blood, which this will take a period of 60 to 100, yeah? So ventricular contraction, the impulse travel through the bundle of His and Purkinje fiber, causing a rapid and powerful contraction of the ventricle, pushing blood to the lung and bodies, okay? So depolarization is an electrical activation, leads to muscle contraction, while repolarization allows the heart muscles to relax and prepare in the next cycles, okay? So can you imagine like how the systems works continuously? That is what we call depolarization, and repolarization. So you can see here, P wave, it starts at the antheriums, then QRS at the ventricular, then it backs to the ventricular repolarization, and it starts back to the depolarization and going on, going on, going on. Yeah. These are examples of how you need to know about the electrical physiology. So P wave is the contraction takes place. They start constructions, then within the 60 to hundreds, then they start depolarized, then repolarized, and all over again. Okay, this basically just nice to know. Okay, so you need to know all these, the type of wave in the ECG lead, but we basically going to talk about P, QRS, and T, and we also will learn about wave, segment, and interval. Okay, U wave is nice to know. Okay, U wave is nice to know. It happens and exists in the very small conditions, but the rest P, Q, R, S, T, we will talk here now more detail. Okay. T wave spread of electrical impulse across the atria from SA node, so it becomes arterial depolarization. Okay. QRS complex spread the electrical impulse to the ventricular, so it becomes ventricular depolarization. So T wave is ventricular repolarization, so it starts all over again. Okay, so what is a PR interval? So you look here, this is a P and R. Okay, so this is really called a PR interval. So what happened during this PR interval? Very important. You need to know this will create electrical impulse spread over the atrium through AV node and bundle of His. But what is the ST segment? This is called ST segment. Okay, this is a ST segment, and the bottom is ST interval. So ST segment is an isoelectric point, no change of electrical activity. So basically, this is a way nothing happened and they will start repolarize. Yeah, and a QT interval, this is a Q, and T interval is depolarization and repolarization of the ventricle. Okay, what I explained, if you find it's hard to know, you look on the picture. You look on the picture, inshallah, you will understand. Okay, you look on the picture number 1. This is what we call depolarized. The P starts, conductive of P start. Then you see, we call arterial depolarization. So the P complete, then you go for QRS. Then ventricular, okay? So from the below, okay, it goes out, then it comes here. Ventricular depolarization begin at apex and progress superiority as arterial repolarized. So then you see, ventricular depolarization complete. So P, Q, R, S settle, then it start repolarization. Okay, begin at apex and progress superiority. The last ventricular repolarization complete. Heart is ready for the next cycle. So this is how you can see the process. Yeah. Okay. Now, for us to start interpret ECG, there are a few things that I need you to understand. The ECG paper. So you need to know about the ECG paper. Just now is a electrophysiologist happens on the conductive or pacemakers. Okay, but now we are going to work out in the details of how this all are going to work out. Okay, so one small box of this is 0.04 second. Okay, and one large box, this is one large box. Yeah, you can see here, this is what I call one large box. Yeah, it 0.20 second or 0.2 second. Then one of these, what vertical, this is what we call vertical, yeah, memanjang, vertical. It has 0.5 millivolt. That's what electrical conductivity. Yeah? Okay. So this is an example for you to understand the ECG. Okay, look on the look on I mentioned to you just now, right? We go back on then you will see this one. This one I say the 5 is a 0.5. So after 5 boxes is a 1 second. Yeah, 1 second. So we can go over here. Can you see now? 1 box, 2 box, 3 box, 4 box, 5 box is a 1 second. This one big box also 0.20. One is 0.4. So I hope this is how important you need to understand about ECG's boxes measure. You need to measure. The principle here is 1, 2, 3, 4, 5. Yeah, 1, 2, 3, 4, 5 is very important. Yeah, 1, 2, 3, 4, 5. It means 1 second. 0.2 is one of the small box. Each one box is 0.04. So I repeat, yeah, this, okay? So you do this one. This is 0.04. This whole box, 0.5. This box times 5, 1, okay? Very basic you need to know, yeah? Okay. So the standard ECG speed, yeah, 25 millimeter per second. This means that the paper moves through the ECG machine at the rate of 25 millimeter every second. So what this means on the grid? So since each small square on the ECG paper represent 1 milliliter, okay? Each small square equal 0.04. So 5 square equal to 0.5. So that 1, 2, 3, 4, 5, 0.2. Why paper speed is important? The speed of 25 millimeter per second helps standardize the timing on ECG reading. If the paper speed is changed, for example, some machine can also run up to 50 millimeter, it will affect how the wave appears, potentially leading to misinterpretation of the heart rate of interval. It's important to always check the paper speed setting on the ECG machines to ensure accurate reading. Okay, how it affects calculation? With a 25 milliliters paper speed, you can calculate heart rate using the R to R interval as explained earlier, and 300 equal to 300, which number of large circle between the R wave. If the speed changes, this calculation will not longer apply, so always ensure the speed is set to 25 milliliter per second. So this is basically an overview of the speed ECG. Yeah? So the key points to remember. ECG paper helps us visualize and measure the heart electrical activity over time. So it's a very important, the ECGs are really giving, by doing a right technique, yeah, which I'm going to cover after this before we go for interpretation, because it's going to give you the right activity of the heart, electrical activity. The distance between wave on the horizontal axis tells us how fast or slow the heart is beating. The height of the wave of the vertical axis show the strength of each impulse. By analyzing the pattern and interval of the ECG on the paper, we can detect normal heart rhythm and identify possible issues like arrhythmia or heart block. So the ECG paper, every 3 seconds, 15 largest box is marked a vertical lines. This helps when you're calculating the heart rate. So you know, if you look here, every 3 seconds, okay, so we told you, right? This 1, 2, 3, 4, 5, 1 second. 1, 2, 3, 4, 5, 1 second. 1, 2, 3, 4, 5, 1 second. So 3. So every 3 seconds is marked as a vertical line. So now you're giving you a better understanding. This helps when calculating the heart rate. Okay, I think this 12-lead ECG, you all know. Okay, basically, I think I'm not going to cover all. Just want to tell you, the 12-lead ECG, it has bipolar leads and unipolar leads. Okay, the bipolar leads is a lead 1, lead 2, and lead 3. The unipolar lead is a ABR, ABL, and ABF. Okay, this is how you become then what is a 12-lead ECG? So we have 2, 4, 6. Then we have 9, 6. Then we have the 3. Then of the 6 limbs that it become a 12-lead ECG. So basically, limb, leads, and chest leads. Yeah, that's how we become the 12-lead ECG. So we have chest lead horizontal plane. These are unipolar leads that are placed across the chest, each at specific location. Give a horizontal plane. So V1 and V2 position near the right ventricular, V3, V4. This at the chest here. Then V5 to V6. So these leads are especially useful for detecting abnormalities in the different part of the heart muscle. So what each lead show? This is very important. So you need to know if this happens some problem in the lateral, inferior, septum, or anterior. So this is how when the changes shows abnormal at that particular lead. Okay, so lead 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and then you will see where the abnormal come of 12. Okay, sorry. So you look on the lead 1, ABL, B5, B6, it view the lateral wall of the left ventricle. Okay, this 4, this 7, yeah. So this is how lateral. Okay, so leads 2, 3, and ABF inferior. Okay, lead at the inferior or wall of the heart. Lead V1 and V2 is septum between the ventricular. Lead V3 and V4 is anterior. So later you can see why people say anterior MI, why people say inferior MI, why people say septum or posterior. You will understand after this. Okay, by examining all these view together, clinician can detect specific issues in various areas of the heart, such as its reduced blood flow, infarction, or arrhythmia. So diagnosing heart condition, the 12-lead ECG is a powerful tool for diagnosing many heart problems, yeah, such as heart attack, arrhythmia, and also electrolyte imbalance. Okay, so it can show if any part of the heart muscle is not getting enough oxygen, detecting location of the heart damage. If the heart attack occur, certainly can pinpoint the affected area. I told you, right, interior, anterior, and posterior orbital lateral infection. So it detects on the this lead. So you need to know now. If the changes happens lead 2, 3, and ABF is a inferior infarction. Lateral infection are lead 1, ABL, B5, B6, and anterior infection is detected in lead B3 and B4. So, assessing heart rhythms, the 12-lead ECG also helps assess the heart rhythm, identify normal and abnormal pattern. Yeah. So this, I think, is a placement of the ECG leads. Just nice to know. Okay, this all are nice to know, which you can understand. Yeah. Okay. So we are now on rhythm. And so we are going to ECG interpretations, and we're going to go for 5 steps. The 5 step here is calculate the heart rates, determining the regularity. Step 3, assess the P wave. Step 4, determine PR intervals. Step 5, determine the QRS duration. Okay. Don't worry, we will go this slowly, then you will understand first. Okay. So you remember just now we mentioned about how to calculate. It must have 3 seconds, right? 3 seconds. Because 0.04 times 5 is 0.2. Then is times 3 times 5, it becomes 1 second. So we will go this and look on around. Okay. So look here. Okay, so 300 divided by 3, it becomes 100 beat per minute if the rhythm is regular. So if the rhythm is regular, okay? So 300 beat per minute, then divide by 2, then divide by 3, divide by 4, you divide by 5, then you will still get the pulse rate. Okay, so this is on the one case. So on one patient, the 300 beat per minute. So it's very rapid, yeah? So patients are not normal. Okay, then this 150 also not normal. But this and this and this acceptable. Remember, 60 up to 100 beat per minute acceptable. So these are normal, yeah? So this is an example. So you need to be very careful. Large square methods, yeah, basically this is how we work out. So if 300 divided by 5, if 300 divided by 4, 300 divided by 3, uh, uh, 300 divided by 2, and 300 divided by 1. So this is what we call the formula. What I would like you to do is always go with the 5 box. Yeah, always go to the 5 box because that it will give you a precise. So divide by 3, then it becomes 100 byte per minute if the rhythm is regular. So this is how normally we come up with it quickly. But now you don't need to count this. It's already given in your ECG strip. Yep. Okay. The option 2, a small square method. So just now is a large square method, but now we go for the small square method. Okay, the square small is a 1,500 divided by 18 here. So why 18? Because they count the small boxes, the small square, yeah? The small square, and then it work on this. So rate is R to R. So this one is P, Q, R to R, yeah, R to R, R to R. So it become like a small box and it become like 18s, divided by 18s. Why? You can count here. This is 5, this is 5, this is 5, 15, 1, 2, 3. So 18. So this is also another formula of count, yeah? Okay, there's another third option. This is the one that I taught you at the very first, the 3 second, 3 second. So count the number of R wave in a 6 second rhythm, then you multiply by 10, then you interpret. So 9 times 10, okay? You see, one R wave method here. So we have nines, 1, 2, 3, 1, 2, 3, 1, 2, 3. So it becomes nines, then you divide by tens, they become this how you get 90 beat per minute. Yeah, I will count the number of in the 6 second rhythm strip, then multiply by 10. So you know why how you get 6 seconds? Remember, this is a 1 second, right? This is a 1 second. So this is, sorry, 0.2 second, 0.2, 0.2, 0.2, 0.2, 0.2. So all of these after 5 is a 1. Okay, that is how you work out with your calculation of this rate. Okay, now let's we go on calculate rate of irregular rhythm. Okay, you look here now. Okay, just now when we say that you see here is 1, 2, 3, 4, 5, 6, 7, 8, 9, then 10, 11. You can see it is not regular, it's irregular pattern of 6 seconds. 30 large square equal to the 6 second, and it's 100 beat per minute of the pulse rate. So find a R wave that lands on the bone line, count the number of the large box to the next R wave. If the second R wave is large box away, the rate is 300. If 2 boxes is 150, if 3 boxes is 100, and 4 boxes 75 also can. So if 300 divided by number of large square is R to R that you will identify. So this basically giving you some suggestion of how to calculate the R rate. Okay. Now is second step. Second step is to determine the regularity. I will respond to your question later. I will respond later. Okay, we are still in the reading of normal ECG. We will go that later as it comes down. Okay, so look at the R to R distance. So using a caliper or marking on the pen paper. So are they equidistant apart or not? Yeah? So okay, so if you look on one glance, it looks so regular, right? R to R, R to R, R to R, R to R. It look all identical, right? It look all identical. So it's a regular. So are the P wave regular here? It exists, right? It's a exists. Do the P wave all look alike? Yes, it look alike, right? Look at the arrow. Do the P wave occur in the regular rate? Yes. Yeah, you can see the boxes here. Okay. Is there one P wave before each QRS? Yes. So normal P wave with one P wave for every QRS. So this is a P, Q, R, S, T. P, P, Q, R, S, T. Yeah, P, Q, R, S, T. That will make really clear on this. You know? So this is called normal, normal P wave with one P wave for every QRS. So determinant of PR interval. Okay. So normal is the, okay. So you know, right? This one box of one box of the five small box inside is a 0.2 second. Yeah. So normal accept range is 0.12 to 0.2. So in between more than one, so in between less than one or more, less than one or one. That is how to precise on the normal. Yeah. So basically, they become 3 to 5 small boxes. So because the 0.04 times 3, it becomes 0.12. 0.04 times 5, it becomes 0.20. So this is a range of the P wave looks on normal. Is that clear? So I repeat, one small box of the one box has smaller boxes, which is 0.04. So one box is 0.20. So the normal PR interval could be taking 0.12, which is 3 boxes, because 0.4 times 3 is 0.12, or it can go up to 5, 0.04 times 5, 0.4 times 5, 0.20, yeah? And this is an example of the interpretations of the QR as duration. Okay, if you look on this ECG strip, it has a clear P wave, QRS, and the segment and T is all looks identical, look regular. So the rate you can rate, right? You can rate the R to R, R to R, R to R. You will get 90 to 95 beats per minute. Then that look normal, P wave normal, zero. Okay, how you get 0.2? Must have a 3 boxes. Yeah, must have 3 boxes. You can check if you look. Yeah, it's got 3 boxes. Okay, so yeah, you got 3 boxes. So that's how P and R interval, and then QR duration is 0.0, but it's called normal sinus rhythm. Okay, normal sinus rhythm. I think you all know this. This is what our heart rate is set, 60 to 100. P wave normal, interval 0.12 to 0.20, QRS 0.04 to 0.12. So any deviations from above of this is sinus tachycardia, sinus bradycardia, or arrhythmia. Is that clear? So this is how you need to understand about ECG parameter. Okay, the summary of this, you need to look on the P, Q, R, S. R to R interval. Okay, R to R interval must have this second. Okay, P P and R interval, Q and T intervals, then ST segment and P and R segment. So all of these shows a normal, basically, normal sinus rhythm. Okay. Okay. But beside the normal sinus rhythm or sinus rhythm, we will then also have arrhythmia formation, which called sinus tachycardia, sinus bradycardia in the sinus node, atrial serial, premature atrial contraction, atrial flutter, atrial fibrillation, and supraventricular tachycardia, and the rest is all premature VT and VF affected. Okay, so look on here now. Why it calls sinus tachycardia? Because sinus tachycardia, not sinus rhythm, because of the pulse rate more than 100. Okay, so if you look on this ECG, it look regular, right? The rhythm is regular. The PR interval is still normal, taking 3 to 4 boxes, so 3 to 5 boxes, and also normal. Sinus tachycardia could happen when you are not in the resting position. You are very high anxious. You could have some failure and etc. So you're just sinus tachy because your heart rate is more than normal range. Sorry, more than range of 100 and above. Yeah. So this is what I call sinus tachycardia. So at atrial arrhythmia are abnormal heart rhythm that originate in the atria, the upper chamber of the heart. They disrupt the normal flow of electrical signals, causing irregular heartbeat. Some common types include atrial fibrillations, characterized by rapid, irregular electrical impulse in the atria, leads on an irregular and often rapid heartbeat. Yeah. On ECG, atrial fibrillation show an absence of distance P. So you remember, AF no P and irregular R to R. Atrial flutter involves a regular but very fast rhythm, very fast rhythms. In the atria, commonly present with the sawtooth pattern of ECG due to rapid P wave and gigi. The atrial rate can be around 230. But what is supraventricular tachycardia? Originate above the ventricle, usually the atria or AV node, cause a rapid heart rate that may start and stop suddenly. SVT is often seen with narrow QRS complex on the ECG. Yeah? Narrow, yeah? You will see all three examples. So all these causes can be high blood pressure, heart disease, excessive caffeine. Yeah, sometimes people taking coffee, they can get very fast palpitations. Are all these the reasons. Yeah. So now you look on here. The rate is 70 beat per minute, yeah? So it's occasionally you can see some irregular. You look here. Here and here and here are not same, right? So 2 over 7 different control. So 0 except for 2 and 7. Yeah, so basically is normal rhythm with premature atrial contraction. So sometimes it's not right, and because the right heart rate is normal, is acceptable. So arterial fibrillation, rapid electrical discharge comes from multiple atrial ectopic foci. So no organized. Okay, you can see basically the atrial is 350 beat per minute or greater. You can see is R to R is not regular. Okay, irregular R to R. Yeah, and PR interval is not exist. Yeah, P PR intervals is not exist because it's flat, and that is why it's called AF. Yeah, this basically normal takes a second or 40 less than a second, but every like very fast. Yeah. So now we go for supraventricular, which I say narrow. Yeah, narrow QRS. Okay. rate is 150 to 150. Sorry, not normal. It's not normal. The arrhythmia such as fast rate, that P wave may not be seen. Okay. So you see the P, Q, R, S. You don't know either it's a P or T. You know, you cannot be very differentiate. So P wave during the T wave. That's how we call. You know, because kita nampak P dengan T. Yeah, that's how you say. Okay. The regular looks identical, right? So it's regular. The rhythm. Frequently during the positive T wave, difficult to see, usually not possible to measure. SVT may be related to caffeine, nicotine, or any other heart disease as well. So this is what very narrow, very narrow QRS. Okay, you can see very narrow. This is a typical SVT, very hard to measure as compared to this. You still can see, but this is actually the real 12-lead ECG. You can say wide QRS here, which is a narrow we call. Okay, you can see very wide. This is a typical SVT. Typical SVT. Can you see that? All leads involved. All leads involved. So let's go to ventricular arrhythmia. Ventricular arrhythmia are abnormal heart rhythm that originate from the ventricle, the lower chamber of the heart. Okay, so this is how you need to understand. This arrhythmia can significantly affect the heart ability to pump blood effectively and may lead to serious complications, including sudden cardiac arrest. So the type of ventricular arrhythmia, a rapid heart rate originating from the ventricle, often defined as 3 or more consecutive beats at a rate exceeding 100 beats per minute. Monomorphic or polymorphic, morphic, is all of the QRS complex look the same. That's mono. If the QRS complex are very inappropriate, it's called polymorphic. So VF is chaotic disorganized ventricular activity, premature ventricular contractions, and torsade points specific form of polymorphic VT often associated with prolonged VT. The causes are the same. The causes are the same. Okay, symptoms are same. Basically, they are disease and SOB. Okay. So, what are the difference between supraventricular tachycardia and ventricular tachycardia? Okay, so so this kind basically you need to understand that supraventricular tachycardia happen at the above of the hearts, it's called supra. But ventricular tachycardia happens at the normals or the bottoms of the and normally ventricular tachycardia, they are normal but they are fast. Okay, normal but they are fast. But ventricular as compared to SVT, these are the things that you need to be very careful. It's called usually regular because it's normal. Okay, ventricular cells fire continuously due to a looping or re-entrant circuit, usually regular 120-50 beats. P wave may be absent, inverted to retrogrades, usually regular, and the complex is bizarre. You can see here, it looks very bizarre, right? Very funny. This is what we call ventricular tachycardia. If you look on the lead 2, this is what it looks. It looks there. Normally, I would refer on lead 2. See, this is what we call ventricular tachycardia. So the P wave is absent sometimes, and QR complex is bizarre, doesn't look properly, look awkward, and this is what we call VF. So, okay, so this is exactly, you can see, this is exactly VT. So you look on lead 2, this is how it looks on the, you see lead 2 here, this is lead 2 here. This obvious look VT. Okay, then what difference between VT and VF? VT is fast, but somehow normal. VF fast, but totally abnormal. Totally abnormal is going to be near death, essentially, because it is not seen anything. You can see, you can't even see what it's all about. The heart is like this, like this, like this, like this. No, don't know, not properly pumping. This is how the VF. Okay, so I think you can see here. This from the lead 2. I go back. You can see lead 2 here. You see lead 2 here. Okay, then you can see that this lead 2 of VT, this is the lead 2 of the VF. Okay, you look here now. This is what we call SVT, yeah, supraventricular tachycardia. Why you call paroxysmia? Paroxysmia is sudden because it has normal, that it's not continuous. That's why you call paroxysmia sudden. Okay, you see the rate is still acceptable, regular, yeah, normal, 0.16. So QR duration 0.08. So basically, it's a SVT. Okay, so deviation from a normal cellular rhythm, the heart rate suddenly speed up and the P wave are lost. That's why it looks normal. All of a sudden, the P wave is okay. You see here, you can see P. You can see P, Q, R, S. Then all of a sudden P is missing, and some abnormal part here, depression. You can see this ST segment. This is how supraventricular tachycardia can happen. Okay, so paroxysmal supraventricular tachycardia is a rapid rhythm that starts and stops suddenly. For accurate interpretation, the beginning or end the PSVT must be seen, and PSVT sometimes called paroxysmal atrial tachycardia as well. So it is a sudden onset SVT. From normal, it become sudden, which missing oil. So frequently preceding T wave. So you mean the P and T you cannot see. That is what we call T frequently buried the in preceding T wave. Yeah, and usually not possible to measure, and this is how the condition could be occur due to the palpitation, disease, or like headache as well. Basically, palpitation. Yeah. So now we go to another point of our learning today is diagnosing MI, which I think the peak of the topic. To diagnose a myocardial infarction, you need to go beyond looking at the rhythm strip and obtain a 12-lead ECG. So you need to have a 12-lead ECG. So one of the acute myocardial ischemic is the ST elevation. Okay, if you look on the P wave, then the QRS, then T, PQRS, then T. However, from this, they call J junction. J is not wave here, it's a junctional. It has an elevation. So this is how giving an suggestive of MI. So ECG is a mainstay in the initial diagnosis of patients with suspected acute coronary syndrome, as I mentioned earlier, which will dictate management. Patients with acute ST elevation myocardial infarct, the ECG evolved through a typical sequence. Okay, this is start to have abnormal looks, but this is the ST elevation, obvious wave that you can see. So it's a new ST elevation at the J point in the two contiguous leads in lead out rather than lead V2 and V3. So this is an example of us to know on the ST elevation. Okay, so localization of MI, I've already told you if it is septal, V1 and V2, arterial, V3 and V4, posterior, tall R wave, and ST depression. So look here, every of these leads, when it has an abnormal, it's MI, but it only giving a suggestion where is the MI happen. Either the MI happen inferior, anterior, or posterior, okay? So when you look on localization of infection, okay, you should look on this LCX mean left circumflex artery, then compared with the left atrial descending. Yeah, so this is how we look out, and the RCA is the right coronary artery. So these are the things where the ECG changes taking happen. You can see a very obvious ST elevations, very obvious ST elevations over here, and the depressions over here. That's why you need to know, is it posterior or all infarct? Okay, I go back over here. You can see if it is at okay V5 and V6. You see V5 and V6. If it is elevated, then it falls on the lateral. Okay. If we go for let's say we go for inferior 2, 3, and AVF. Yeah, 2, 3. You see ST elevation. So it's inferior. So this basically you need to know about where the infarct is happening. It's a very obvious of lead 2. Okay, we have a long lead 2 here. This typical ST elevation. You can see, right? Yeah, learning ECG is not easy. You really need to be with them for very long. Then you have to familiarize. But of course, today will give you an understanding of all these things. Okay. So anterior MI. If anterior MI, we go back here. Anterior V3 and V4, right? Where is V3? Where is V4? Obviously, you can see. You see, even from here, but not much a lead to here, but you can see obvious from here. This is what we call anterior MI. Yeah, this is the pattern of anterior MI. So anterior MI very obvious that you can see from there. This is the part. Yeah. Okay, inferior MI. So when we go for inferior MI, where is inferior MI? 2, 3 AVF. 2 ST elevation, 3 ST elevation, and what inversions, yeah? And these are obvious, like AVF. You see, ST elevation in U2, 3, and AVF. Where is AVF? You can see here. Yeah, this is AVF, yeah? So this is how we learn about inferior MI. So if the 12-lead ECG look like this, it is an inferior MI. If it look like this, anterior MI. So ST elevation in lead 2, lead 3, and absent reprobable, change in lead 2 can, sorry, or I think, there's someone asking the question. I want to put aside my slide. It has deleted, has share.
Okay, you can go on to your own presentation first, and
Okay.
we have another time for a question and answer section.
Okay.
So you can go on. I'm sorry, Professor Said, you
Yes.
have 5 minutes left.
Okay. I try to finish it. I know what happened. My slide cannot be seen now. Why is it not coming? Okay, share. Okay. Share. Oops, okay, I don't know why. Okay, I share again. Okay, I go to big screen. Can you see my slide now?
Yeah.
Okay.
Yes, your slide is already clear.
Yeah,
You
okay. So
can
now I have to go quickly,
continue.
okay? So this is basically the posterior MI, as the posterior bicular is not directly visualized, so you need to understand this by standard 12 ECG changes are sought. So you need to know anterior, posterior, infarcts, yeah, has to be very clear on the wave, as I mentioned earlier. So this is a posterior MI, typical appearance in a V2. Okay, you can see how it depressed here of the ST parts. Okay, this is the posterior MI. You can see basically the same direction. This is how you can look on the here. Yeah, you can look on here. This is how the elevation happens. Yeah, so anterior, posterior, part that you will really understand now on the infections. Okay, this is an example for you to read. Okay, we'll go what is heart failure. Basically, heart failure is lifelong condition in which the heart muscle can't pump. Yeah, basically it's all about right side heart failure, left side heart failure. All the enlarging. Yeah, pumping faster, and etc. So the blood vessel narrow to keep blood pressure, trying to make up for the heart loss. The kidney retain more salt and water rather than excrete through urine. This is all about electrolyte imbalance. Yeah? This create increased volume of blood, yeah, and etc. Okay, this normal heart and heart failure. So these all the things that you can read later. You will get, I've already put summary on this, but now I'm going to give conclusion. So the conclusion here is basic ECG principle. You need to understand on the wave forms of recognized PQRS, measure P, PR, QRs, and QT intervals, and see any atrophy. So identify is about ischemic on ECG. So it's ST depression and T wave inversions indicate myocardial infarction. And ST depression is a horizontal or downsloping deviation. So upward deviation above baseline and T wave negative depression indicative necrosis. Okay. So supraventricular tachycardia typically 150 and 250 beat per minute. Narrow QRS, absent P wave. This is how you need to know about of in exam, they always ask here what is the difference. So these are the answer normally. So the ventricular tachycardia is also absence B wave, wide QRS, narrow QRS, wide QRS, and rapid rate. Okay, the ECG finding arterial enlargement, ventricular hypertrophies, which increase the QRS, all the arrhythmia, and this is a case study. A 65-year-old male present with the chest pain. ECG show ST depression in the leads. Yeah, V4 and V6. You should know, right? V4 and V6, which type of myocardia. Okay, and the findings suggest myocardial infarction. Patient presented with chest pain, FT depression, and T-wave diagnosis myocardial infarct. Yeah? The last case here is a 70-year-old female present with acute onset chest pain, ECG revealed ST chest pain, ST elevation in leads to for AVF as well as Q-wave. This indicate inferior, acute inferior myocardial infarction because of the lead. Remember the leads that I shared. Okay. This is all you need to know. You have to do accurate analysis, then appropriate patient interventions, then taking history also very important. Thank you very much from me.
Okay. Thank you very much for your amazing presentations, Professor Said Jeswet. And please giving applause to our keynote speakers. Yeah, I would like to express my sincere gratitude for these outstanding presentations. The topic discussed today was truly captivating, and we are going to moving to another sections is the question and answer sections. So we have already the questions here, a few questions in the chat room. The questions coming from Rukia Lun. Okay, the question is, excuse me, I want to ask about ST segment that no change in electrical activity. What it mean?
Okay. I think you need to understand that from my beginning topic of this ECG, I say electrical conductive of pacemaker of the heart, but it also interrupt all those things by electrolyte imbalances. So when you have electrolyte imbalances, then you need to do a provisional diagnosis. That's to distinguish, are these having acute coronary syndrome problem or having electrolyte imbalance, because electrolyte imbalance also affect the ECG. Is that clear? So when there is no changes, it means there is already electrolyte platforms. Because in my presentations, we talk on MI, SVT, VT, and heart failure. We don't talk about electrolyte changes. That's why I didn't cover on the U wave. I didn't say calcium can cause all this. I didn't cover in my presentation.
Okay, I think the answer is really clear. So I really appreciate for the Rukialun for the question, and thank you very much, Professor Said bin Nurulma, for the answer. So we are moving to the another questions. Here the questions coming from Nurse Fitria Wahyuningsi. Okay, and the question is, good afternoon, sir. I would like to ask, Why electrolyte imbalance reason to atrial arrhythmia and how to pathophysiology. Thank you in advance.
Okay, thank you, thank you. I think all of you interested in electron imbalance. Actually, my topic didn't cover electron imbalance. You are right. You are right, Nitya. Actually, when you have the electrolyte imbalance conditions, you are right. They will come out with the arterial arrhythmia because when the heart is cannot pumping properly, arrhythmia happens. But why electron imbalance reasons? Because of the abnormal conductive happenings. Okay, so it could be your kaliums, potassium, your sodiums, uh, is something haywire happens. That's arrhythmia. So you are right. When electrolyte imbalance, this end up arrhythmia.
Thank you very much, Professor Said, for the answer. And please giving applause to the our keynote speakers for the answer the questions. And I would like to say that thank you very much to all the participants who still actively in this our discussion sections. And we are moving to another questions here. You have so many questions here because I think this topic is really interesting.
I
So
know
that's why.
it is a hard topic. It has to be like very face to face, carry all the electrolyte, teach one by one. But I know in online it's quite difficult. I'm sorry about that, but
Yeah.
don't worry. You try to best. Okay, there's a one question here.
Yes. Okay. The next question is coming from Muhammad Ulil Amri. And the question is, thank you for your presentations, Professor. May I ask about the concept of the heart axis? How to understand the sieve in the QRS axis transition zone in the precordial leads? And what is the relationship with the term clockwise and the counterclockwise rotations? Thank you, professors.
Okay. So I think I try to understand his question. He's asking how QRS exists transition. Okay. You remember when I mentioned to you earlier about depolarization and repolarization? That is the peak of this happening. So that's what we call axis. Okay. But your second question say in terms of clockwise counter and clockwise rotation, because after the process complete, reprocession and they will start all over again. And that's what I can try to understand your question. It is a process. It is a process of the conductive on the depolarization of atrium, ventricle, as we note, then it repolarize and you start all over again with the flow. That's what I call clockwise.
Okay, thank you very much, Professor Said, for your answer, and thank you for Muhammad Ulil Amri for your participations to these question and answer sections. And okay, this is the last questions, maybe, Professor, but actually, this is the out of the topic for our topic today. So I will try to translate in English, but this is that's your right. Is it you want to answer the question or not? Is it
I try my
just
best.
up to me? Yeah,
Okay,
because this is out of the topic, but it's yeah, you have the fully right to answer or to not answer the questions. So I will try to translate in English. The question is from Eka Swarida. The question is, for the patient with a chronic kidney disease with the hemodialysis, have often had the thrombolysis on the semino or the axis of their hemodialysis, like semino or CDL. The point is, if there was any obstruction, is it can affect to the heart or to the our cardiac system?
Yes. The answer is patient will come with bradycardia because there is a block, not processing. Then it could happen brady. Then slowly it become a heart failure because of circulations happen. So basically, that is another cause of embolism, right? When you call when you have a blood clots it is life-threatening, dangerous, yeah, dangerous. So that's why you have to be very careful to have anticoagulation before you do all those to make sure that there's no blockage. I think that's the clear-cut answer on her question because she say, is it affect the heart circulation? The answer is yes. Then it will also affect the ECG. Anything abnormal activity happen in the hearts, it will affect on the conductive electrophysiology of the ECG.
Okay, thank you very much, Professor Dr. Muhammad Said bin Rumal, for your amazing presentation. We can giving a really a big applause to our keynote speakers, and I would like to express my sincerest gratitude to the outstanding presentation. The topic discussion was really, really, truly captivating. And as there are not a further question, I will conclude our Q&A session for today. So thank you very much, Professor Said, for your amazing presentation and also for this seminar. And before we'll leaving before we going to the next sections, so I will let you to give the take-home message to our participants.
Okay.
So the time is yours, Mr.
Thank you very much.
Professor Said.
Thank you very much, Fazal, for your wonderful become the master of ceremony for or chairperson for my slot. I think my whole message to all the learners today, learning ECG is not as straightforward. So you need to look and see and understand, then inshallah you will learn something. But today we talk about SVT, VT, we talk about MI, barriers of MI. That's why my coverage on that topic. But some of you are interested to ask more about electrolyte imbalances. That's the difference, which electrolyte involved that making the electrocardiac changes. Okay, so I wish you all the best. Keep yourself familiar with ECG. Look every day, learn every day, and one fine day you will understand ECG. That's all from me. Thank you very much. Have a good weekend, everyone.
Thank you very much to Associate Professor Dr. Muhammad Said bin Nurul, and we can give a big applause to our first keynote speakers. Okay, thank you very much, and see you in
Next time.
Our welcoming. Yeah, see you next time.
Bye-bye, everyone.
Bye-bye.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you very much for Professor Muhammad Said bin Nurul for their really extraordinary presentations. And for the next section, we have another seminar sections with Mr. Winit Longlaren. But before we start it, I think Mr. Winit has joining with us in this Zoom meeting. So we can ask the Mr. Winit to join with us. Okay. Good afternoon, Mr. Winit. Halo, Mr. Winit. Oke. Baik, teman-teman Sobat Cito semua, tadi sudah selesai untuk sesi yang pertama, di mana untuk sesi internasional yang pertama bersama Profesor Muhammad Said bin Nurul. Ya, untuk selanjutnya kita akan melanjutkan kepada sesi yang kedua bersama Mr. Winit Longlaren, ya, dan Mr. Winit sudah hadir bersama kita. Oke. Hello, Mr. Winit. So, how are you today?
Hi, thanks.
Okay, I'm sorry. Your voice is not
the
really
voice,
clear.
The voice so loud. Do listen me, okay? Clearly, yes, okay.
Now it's more clearly. So we can hear your voice really clear right now. Okay. So how are you, Mr. Winit Longlaren?
Fine. How are you, Mr.
I'm Faisal. I'm sorry.
Okay.
I'm sorry. I haven't introduced myself to you. My name is Faisal Azari, and I will be your moderators for this session seminar. So before we are going to our topic, please let me to introduce yourself to our all the participants, and I will read your curriculum vitae. So. Baiklah teman-teman, saya mohon izin untuk share screen CV dari pembicara kita yang ketiga. Ya, pembicara ketika kita, beliau adalah Mr. Winit Longlalern, MSc, MSN. Saat ini beliau aktif sebagai Specialist Nurse and Advanced Nurse Practitioner Heart and Vascular Disease, and also as a Manager of Center of Excellence for Cardiovascular Disease. Ya, ini riwayat dari pendidikan beliau dan juga riwayat untuk pekerjaan beliau. Pastinya sangat luar biasa sekali untuk pemateri kita saat ini. You have really an extraordinary experience, Mr. Winit. So without any further ado, let's joining to welcoming our speakers, Mr. Winit Longlalern, MSc, MSN. Please giving applause.
สวัสดีครับสวัสดีครับ Good afternoon good morning everybody and how are you today and so good day today and this presentation of the EKG interpretation. I'm hearing my your professor Mr. says and so is every two persons so and adaptation of the PowerPoint because it's the same but I want to is the advanced EKG interpretation to its book have the heart block or it heart failure and this ECG is changing in this working of nursing care unit and share look okay. Just a minute, please. Okay, looking at my PowerPoint, Mr. Famati, you looking
Yeah.
at me?
Your presentation is clearly on the screen. You can
Okay,
continue
your
your
screening, yeah,
presentation.
continue presentation. Okay. Thank you, Professor, and thank you. Is the International Web Seminar Advanced EKG Interpretation to this Web Seminar International. And my name is Winit Longlalern. I'm the ECG interpretation of ischemic heart disease, ischemia as supraventricular tachycardia, ventricular tachycardia, and heart failure and heart block. Okay, from senior profession, nursing department of Korea Artery Thammasat University Hospital and the Excellence Center of Cardiovascular. I'm diplomat, the Thai Board of Advanced Practitioner in Adult Gerontological Nursing, Advanced Practice Nurse, and Master of Nursing Science Program in Nursing, and Master of Science Program in Human Sexualities. I'm in this from in the Thammasat Universities. Is the leading to hospital international level modern with attentive service and mission providing excellent and caring healthcare promotion health through in the integrate of health service, education, research, innovation, and modern technologies. In this Center of Excellence of caring to non-invasive, invasive, intensive care ward, electrophysiology study, and heart failure, and technique and training, medical study, resident internal medicine, fellowship of international cardiology and cardiac technician, everything to is in this cardiovascular disease is atherosclerotic inflammation disease of the smooth muscle cell and perforate of the plaque rupture and is occlusion of the vessel in your heart. And the acute myocardial infarction is cause of coronary and the background. This pathology occur cause permanent change of the heart muscle illness from acute myocardial infarction affect to ability, activity, and work which reduce of quality of life of my patient. And Thai acute coronary syndrome regency report, the policy of patient in acute coronary syndrome. The Dr. Arun P1 is looking at this graph to is ischemic heart disease. So many people is just both cardiovascular disease by country in Southeast Asia, and this burden attribute to the select risk factor is looking at is the metabolic risk and behavioral risk. If you have the person, you have in 10-year cardiovascular risk of adult 50 or 54 years old according level to risk factor. If you have A, B, C, D, the risk factor so very many much to acute coronary syndrome in men and women. Okay. In the mortality rate in population from NCD disease from in Thailand, the coronary artery disease is 31.5 is per 100,000 population from NCD disease. And mortality rate is the top 5 in Thailand. Service plan of cardiovascular disease in Thailand do is acute coronary syndrome, SC-MI, open heart surgery, pediatric heart disease, heart failure clinic, and anticoagulation clinic in Thai health policies. Summary, the policy in patient with acute coronary syndrome, you'll have health literacy for the patient to recognition the acute coronary syndrome, alarm symptom and access to medical care, and set up cardiac center referral system cover area of Thailand and high emergency of SC-MI fasting track system in each health recognition, increased reperfusion fibrinolysis is the fibrinolysis for primary PCI or pharmacoinvasive strategy, collaboration NCD for screening and control cardiovascular risk, national data management, Thai acute coronary syndrome, and KPI key performance indication for SC in Thailand in hospital, more decreased mortality rate, lower than 9%, and reperfusion therapy and specific time is above 60%, and new KPI is the 30-day mortality rate is lower. In the American Heart Association is 2023, look at share the decision making of the patient and cardiovascular risk, health literacy, and social support, social factor, cultural and spiritual factor of home and non-food environment, and the nature of clinical care team, the nutrition expertise, physician activity expertise, clinical expert, and the expertise of the patient education expertise. Physical examination so very important of the nursing care. Physical especially from the chest pain because of the missing of the diagnosis, because of the person who have the chest pain, many symptoms and many areas. Look at this from this the picture. Locally is localized in the shade, common community mid shade, or is the mid shade and inside arm, left arm, or shoulder arm, left or right arm. Upper abdomen is looking at the samely the symptom of the GERD or is the peptic ulcers. To this of the larger area, chest, neck, jaw tract, and inside arm, lower central, neck, both upper neck, jaw, and ear to ears. Inside right arm, left arm, between shoulder and blended. To this above in this area of the back pain, this symptom, and this symptom recognition, my patient, your patient is 50% of MIR silent because of the diabetes, movement overweight, and eggplant dyspnea. You're looking at the patient is to have the diabetes mellitus, okay, is the peripheral nerve, so is the sensory nervous system is not having. And it's local of the nursing process, nursing assessment, using diagnosis, planning, intervention, and evaluation. So very important to nurse is the to describe my patient and 3R, do very quickly. Sign, symptom, allergy, medication, part illness, lack oral intake, or onset, provocation, quality, radiation, and severity. To take in history using principle. Okay, sample or PQRST are the same is the screening my patient because symptom of the early warning sign in acute coronary syndrome is the recognition to dyspnea, chest pain, palpitation, syncope, and edema, syndrome, fatigue. See all the had in this the paper of the in the evidence base 10 heart attack symptom and early warning sign, painful, fullness, short throat, shortness of breathing, nausea, vomiting is the symptom. This from low cut output, sweating, heartburn, arm pain, upper back pain, and these are general malaise and no and the person is no symptom. Yeah, about is a quarter of the heart attack in silence without chest pain and new symptom. Wow, very dangerous. And this acute coronary syndrome to its overall conclusion is unstable angina, non-AC elevated MI, and AC limit. The nurse is the recognition of unstable angina is chest pain 15 or 20 minutes for or got better with nitrate and medication ECG not SC elevate and SC depressed T inverse. Cat enzyme marker negative. Non-SC elevate chest pain for more than 20 minutes. Symptoms do not improve. And ECG ST depressed or T inverse. And especially cat enzyme positive. In EC elevated MI chest pain more than 20 minutes. Symptoms do not improve. ECG elevation or new Leberman block and cadence is positive. Okay, and Sebentana non-SC LMI and ST LMI. We will not wait for the cardiac enzyme assessment and looking at the protocol to the rate of cardiac enzyme the patient, and we will not wait for the cardiac enzyme result because it takes 3 hours for the value to be high. And is of one is a symptom, chest pain, and EKG monitor, EKG 12 EKG to interpretation. Acute coronary syndrome, my professor, today my professor is describe of the acute coronary syndrome, AC11MI, AC depressed, and inverted T. I told so quickly to describe. And ischemia inverted T injury is accelerated in infarction is Q-wave pathologies. Okay. Myocardial infarction is an infarction zone of ischemia. It's looking at of the to the tissue of heart, endocardium. Above of your heart, epicardium. The middle is myocardium and inner endocardium. You have the zone of ischemia inverted T, epicardium, ischemia. Zone of injury is the myocardium. If you have the not to primary PCI or is a fibrinolysis to endocardium. Zone of infarction, FQF of EKG. Pre-hospital logistics very important of care, and time is muscle. Okay, and in this ESC guideline or the American Heart Association guideline, HA guideline, look they have to describe in from this patient chest pain to the first medical impact is 120 and 20 minutes to the hospital. If you have the above is FMC first medical contact above 120 minutes to the fibrinolysis, or the people is to the hospital is can primary PCI center. You have the in HA guideline is 90 minutes, or is the ESC guideline, European Society, is the 60 minutes. And in this of the EKG in ER, the people as ER to the ECG is 10 minutes, lower 10 minutes, not above 10 minutes, very quickly to decide and run EKG. Okay, and to take the, if you have the primary set to the center is primary PCI is 90 minutes to primary PCI. Why diagnosis to why crossing time? Okay, and in this Thammasat University or guideline of the ASC guideline, highly risk is early in non-SCLMI is lower than 24 hours invasive strategy and class 2A. In Thammasat University, try is a high risk to the to the early invasive strategy is the 87 to 90%. And this area summary important to target maximum for medical contact to ECG diagnosis to either lower than 10%, and maximum for medical contact is 120 lower than the 120%, maximum SC diagnosis to while crossing time 60 minutes, or maximum to from SC EMI diagnosis to while crossing time transfer of patient is lower than 90 minutes. Okay. And this ECG monitoring the oxygen saturation in these people is keep not lower than 90%. Okay, if above 90% because of the you have very much of oxygen to the patient, you have the oxygen toxicity, you have the vasoconstriction, not perfusion to this multi-organ, and it's keep oxygen saturation above it or equal 90%. And so those antiplatelet, the nurse is no dose of antiplatelet aggregation and perinatal therapy in primary PCI, aspirin, clopidogrel, prasugrel, ticagrelor, okay, and parent and in this area. Acute coronary syndrome, algorithm assessment of action, last update, okay, in this syndrome, resuscitation of ischemic infarction, and in this two is the aspirin, oxygen, EKG, EKG, and activated cardiac cath lab, morphine or release pain controls, and the considering of the decrease of chest pains. Okay, a conclusion of ischemia, injury, and infarction, which is my passion. Sorry. And to this EKG looking that is SC elevation and Q wave progression. Do have the segment T wave inversion and Q wave. If looking at EKG have Q wave, the patient so where the symptom very dangerous, and because of the myocardial infarction so very much. Okay, if it's a deep Q wave, and myocardial infarction pattern, segment elevation due to my professor, and location of infarction. Okay, the professor of says is the septal wall, anterior lateral wall. Okay, everything you pass. And nurse is not know and recognition to the wall. Yeah, looking at it, 1 or 2, 3, and AVF inferior wall, 1 AVL, V5, V6 lateral wall, okay, and V1, V2 septal wall, V3, V5 is anterior wall, V5, V6 is lateral wall, the position of your chest, okay, septal wall, 1, 2, septal wall is low, is okay, 3, 2, 3, 3, 4 is lateral wall is in front of your cell, and lateral wall V5, V6, okay, is the side of your body. And looking at the EKG, silhouette, it look like it tombstoning, okay, and J point tombstoning, and anterior wall, and looking at V2, V3, V4, okay, anterior wall, and 2, 3 AVF is reciprocal chain of the anterior wall. If have the symptom at 2, 3 or AVF, reciprocal chain of inferior wall is anterior wall. Reciprocal chain of anterior wallคือ inferior wall. Okay. The factor infarction of the to inferior wall. Looking at if my picture is PowerPoint is the label. Okay. Sorry. And show. Okay. Sorry, sir. But fresh. Why?
It's something problem, Mr. Winnie?
You have the label in my PowerPoint. I don't know if the effect here. Okay. Yeah, looking at it, I don't and the label is the looking at the blue here. I don't.
You can erase by using the by clicking the annotates in the in your left side.
Point option.
No. In another side. In another side. Not by clicking that toolbar. It's another toolbar. The toolbar is there's on the top of the audio symbol. Audio symbol.
Not use symbol. Okay, not the serious for me. Okay,
you can continue the slides.
Okay, continue anterior wall slides here. Anterior wall and inferior wall 2, 3, and AVF, and the inferior wall. You're looking to this area, and from this inferior wall is look that the person do everything. If you have EKG inferior wall, you must run V4R and V3R because you detect RV infarction. If you have the patient is inferior wall and have infarction, and the patient, the doctor is the order to nurse is the nitrate drip. Nitrate drip is to decrease chest pain symptom. You have looking at EKG V3R and V4R have. You must stop nitrate and notify the doctor. Early notify because the nursing care and the doctor to provide this IV fluid from in this to my patient above is 100 to milliliter per hour because of the increased volume to this above of cardiac output because you have nitrate or the vascular dilate medication is the very lower blood pressure and low cardiac output. Okay, the nurse recognition, you have the inferior MI, you must run V3R and V4R again, and detect RV infarction curves. Okay, and this the symbol is one writing to the doctor V4R, V3R, the doctor to the right here. And if posterior MI, looking at the posterior MI, I know to the detect posterior MI. The posterior MI it detect from V7, V6, V7, V8, and V9. Okay, in this batch. And lower than V6, V7, V8, V9, 2, and V1, V2, and V3. Looking at you have if you not the run V7, V6, V9, looking at is 12 EKG. You look here in V1, V2, and V3. V1, V2, and V3 have the is an increase of the R wave and ST depressed in V1 and V3. Is the looking like especially from the posterior MI. In normal V1, V2 had the minimal R wave. If you look at is the lager of R wave in E1, V2, and V3, and depression of V1 and 2, V3 is the specialist of posterior MI. In EKG, that's you have the inferior MI and posterior MI. And then you see to inferior posterior MI. Okay, two sides, inferior and posterior infarction. Okay. ห็นไหม looking at V1, V2, and V3. Okay. The minimum of the V1, V2 is so is big. If the normal V1, V2, V3 is smaller in normal, but abnormal is high or highest of the V1 to V3. Okay, and ST depressed in V1, V2 to V3 is the posterior MI. If you can run ECG to add the run V7, V8, and V9. Looking at the picture is the tombstoning. Tombstoning is concave side in V7 to V9. Consequential artery occlusion to is the VT, heart failure, and cardiac to blood to detect and protection of heart failure and cardiogenic shock. Nursing care in integration and reading EKG electrocardiography so very many important for nurse, and electrocardiogram help to indication rate, rhythm, and heartbeat, help to the understanding mechanical diagnosis, cardiovascular disease, various type of arrhythmia, and effect of drug electrolyte imbalance. Therefore, assess the electrocardiogram is a kind of nurse understanding and pathology of disease. Result is nursing care that's fast and high quality, so that patient as safe as possible. Looking at the EKG. Look at the standard bradycardia interval. So regular sinus arrhythmia. Okay. Looking at and monitor. Are they lower than 6 beat per minute? Yeah, PVC. Wow. Short run VT. Looking at what is EKG? Pulsar deploy. Looking at the show the defibrillation to 100 June to and CPR your patient from a squad cardiac life support. If you not looking at EKG and you not to caring for the patient and turn the ECG Pulsar deploy to VT and turn off to the EKG is the ventricular fibrillation. Every 1 minute, if you are not said like the patient. There is the rate of death to it the 10%. Every 1 minute rate of death above 10%. Okay, and VF. So VF. It looks like VVF. I mean, VVF is also wow to this quite quickly to the patient and CPR to the defibrillation from the bed and defibrillation is 200 Joule if biphasic. Very emergency. Every 1 minute increase death 10%. If you not to save life, my passion is in 10 minutes. The people sure, make sure that okay, it's very important in the detect of the EKG interpretation. And assistantly, I don't like assistantly and the nurse from worldwide not like assistantly because the by patient for the symptom, the death and CPR and the adrenaline as soon as possible to ask my patient. Okay. And acute coronary syndrome. I is have to this of coronary artery anatomy and looking at the anatomy of the vessel to coronary artery in the right coronary artery, left anterior descending coronary artery, and left circumflex. If you have the occlusion of the right coronary artery is the support of pacemaker of your heart, SA node and AV node. If coronary artery disease, occlusion, or ischemia or infarction, your heart is pumping is a low heart rate or heart block. Okay, remember please, right coronary artery occlusion. Right coronary artery is 1, 2, 3, and AVF, inferior MI. If you have the artery of inferior MI, you have your patient either heart rate body or bradycardia or heart block. Okay, and is looking at the anterior wall, it cover of left ventricle, total left ventricle. If you have occlusion of LAD, if total occlusion left LAD, okay, is because of the support of left ventricle. If the occlusion is not have the blood circulation from the area left ventricle, you have the left ventricle infarction. It have the decreased heart pumping, so is the to it heart failure. If you LAD occlusion, the patient is the heart failure. Okay, right coronary occlusion is a heart block or bradycardia, and LAD or main left main disease is opportunity to the heart failure. Okay, remember this, please. And looking at the right coronary and left coronary artery do inferior because to describe it the coronary supply. Okay. And cardiac conduction. Okay, restore quickly. To primary pacemaker SA node. Okay. And so pacemaker quickly to try my professor to describe for you today do everything. And normal heart and SA node to AV node. Look at the lines here. SA node, AV node, SA node, AV node. And the Goldman, looking at V1, V2, V3 in textbook of Goldman. Okay, and V1, V2, V3 is the lower of R wave. The lower of R wave, if the above is the larger of R wave, is abnormal ECG. V1, V2, V3, and R wave is slowly to larger. Okay. To precordial chest lead. receptor wall, anterior wall, and lateral wall. Remember, electrode. In the clinical, do electrode is the trade lead is to the three lead standard and the 5 lead standard. If you have inferior wall MI, you add the 2, 3, or AVF, you use of the 3 lead standard. That's okay. But you have the the patient have the SCLMI from the anterior wall. You must stop to this the 5 lead standard because of the brown list to detect of V lead. Okay, V2, V3, V4, and brown lead to and do the nurse is the suggest to this the nursing care 5 lead standard and 3 lead standard to the criteria of the my patient is infarction area. Arrhythmia definition, everybody, general, bradycardia, tachycardia, and paroxysmal. Paroxysmal arrhythmia occurs stop sudden and intermittently. If speed and slowly, paroxysmal. Paroxysmal is meaning, okay, speed and slowly. Recognition, what is the arrhythmia? Irregular heart rate, exciting disturbance or conduction excitation, rhythm then from the heart rate above 100 beats per minute tachycardia or is lower than 60 beats per minute bradycardia, or the factor related to arrhythmia nurse is the cause of factor-related arrhythmia. Direct factor, ischemic heart disease, myocardial infarction, pericarditis, valvular heart disease, or indirect electrical imbalance, respiratory cirrhosis, alkalosis, metabolic syndrome, hypoxia, okay, or medication, food, tea, coffee, or insomnia. And nurse detect to the direct factor and indirect factors. Standard definition of truth of standard bradycardia, standard tachycardia, and sixth sentence syndrome. Look at that sixth sentence syndrome. Abnormal SA node function during while resting exercise result is significant cardiac rhythm change, such as bradycardia and tachycardia. Sir, look in this of the bradycardia from standard standard arrhythmia, standard arrest, sinoatrial block, or an atrioventricular block, and from bradycardia. Or AF, SVR, supraventricular response, atrial flutter, functional rhythm, or idioventricular rhythm. Looking at the picture, synapse atrial block, SA pause, synapse arrest, synapse and sixth sense syndrome. If you looking at the patient is PQRST and pause so long, it's a synapse pause or synapse arrest. Okay, and pause arrest. If you have the synapse arrest, it in 3 seconds is abnormal. It's very abnormal. You as a notification notify but the doctor and such as cause of the synapse pause or synapse arrest. Okay, PQIST and pause. Synapse arrest. Okay, irregular heart rate pause. If you pause above 3 seconds, is very important. Cause of synapse arrest, hypoxia, myocardial ischemia, infarction, hyperkalemia, digital insitolis, okay, medication, everything cause. Side symptom is synapse cause synapse is hemodynamic compression such as weakness, lightness, dizziness, or syncope from the lower blood pressure. If you have the synapse pause or synapse arrest, do you know SA block, synapse arrest, or sinoatrial block is the SA block type 1, type 2, and type 3. Do you know? Looking at the SA block type 1, so is from here, not less than 3 seconds, and but is from the type 2 above of the R to R. R to R to R, R to R, above longer than R to R person in this year. But an SA block type 3 above longer than 2 R to R's, okay, and longer, so very longer is SA block type 3. SA block have the SA block type 1, type 2, and type 3. Okay, if so long, so very dangerous. If long is dangerous. If long is dangerous. And so many symptoms. If so long, so many symptoms. Cause of block and prevention of nursing care SA block. Okay, if the episode of SA block transient or significant sign and symptom, hemodynamic, okay, blood pressure symptom, and adult algorithm, you recognition adult bradycardia algorithms. If you have the atropine IV, okay, by notify the doctor and atropine. If you have atropine and looking at my symptom patch, the symptom of my patient, answerable bradycardia. If you have answerable hypotension, okay, acute altered mental status, sign of shock, ischemic comfort, acute heart failure, okay. I remember from this the unstable is the hypotension. So is many symptoms show in the clinical. Okay, shock, chest pain, and heart failure. The classification of arrhythmia, bradyarrhythmia, more is tachycardia, narrow QS complex, and wide complex tachycardia. Is narrow QS complex, RVR, right? Without response, SVT, WPW, Whoop, Parkinson, White syndrome. Wide QS complex tachycardia, VT and VF. Okay? Sinus tachycardia roll above that rate above is 100 minutes. Symptom, palpitation, treatment, direct cause, okay, nursing care, check task, direct factor, or indirect factor, detect of medication patient have, okay, okay. SVT, looking that, not looking at P wave because it's blur of P wave. Mr. said, Professor said, is describe you to is a SVT very good. This mong let in this blur P wave and not P wave because of the tacky is very tacky of the ventricle is supraventricular tachycardia, so fast that can shift P wave. Okay, SVT, AVRT, and AVNRT, narrow complex tachycardia. So it means SVT. If unstable tachycardia, SVT, those detail narrow, unstable, you have to so quickly to nursing care my patient, okay, unstable SVT, okay, BP drops, okay, alteration of mental status, hypotension, sign of shock, in my patient, look, related to the dose of synchronized cardioversion, initial recommend dose, narrow SVT, unstable SVT, narrow regular 15 or 100 June stat. Okay, if you have the patient if good condition, you don't you have your the medication to relieve of to the that relief of pain before the synchronized cardioversion. Okay, narrow regular regulation in the SVT. Dizziness, shock, chest pain, heart failure. Yeah, ECG supraventricular tachycardia. Important nursing in case of vital signs are stable and non-stable. Okay, if vital sign is stable, is notify my doctor, you had a dose of the doctor will consider at everything of the vagal reflex. It to Warsaw maneuver or adenosine 6 mg ibuprofen technique. In case centralized reduced to dose of 3 mg, you can repeat adenosine to 12 mg IV according to the treatment plan. Okay, what this patient is unable, the doctor consider to the of the synchronous cardioversion 50 to 100 joules. Okay, management SVT depend on the hemodynamic, unstable or stable. Your decision making unstable or stable. Looking at sick, looking at if the person you have a syncope, okay, my patient is syncope. You detect from the in this call to the doctor. The doctor is takes a holder monitoring 24 hours and is the printing of 24 hour. Looking at the EKG is quickly and slowly, and looking at is sinus pause, and pause if the type of SA block. Very good. Type 3. Okay, so very dangerous. The people on my patient, the patient must to the investigate if to the doctor do on pacemaker, the must on pacemaker, because pacemaker to the stimulant to the heart pumping and EKG to the normal ECG. Okay, looking at the EKG, Wolff Parkinson White syndrome. You have the right EKG have a delta wave. The patient you have a syncope to the symptom is the syncope. Pre-access to the EKG 12 EKG. Looking at it have delta wave at the diagnosis to the white Parkinson White syndrome. White syndrome has a person to the research in this from the EKG, the Parkinson White syndrome. Okay, when the stimulant so very quickly, short PR interval, and the name is delta wave, Wolff Parkinson White syndrome. Okay, it can be life-threatening symptoms, sudden tachy pulse rate, difficult measurement, decreased endurance to activity, and syncope to activity. Treatment, electrophysiology study, and radio frequency ablation. Okay, treatment of the Wolff Parkinson syndrome, EPS ablation. Okay. To the VT, ventricular tachycardia. Okay, VT, ventricular tachycardia, looking at more normal ECG. The ventricular tachycardia, looking at is the same, is the shape, is more, is the recognition, is the name ECG. Sorry, is the name ECG is the monomorphic VT. Okay, monomorphic VT. Asset EKG, record DVT characteristic. Okay, and continuous asset patient condition, vital sign. You if looking at VT, you have show of the check pulse. EKG is monomorphic VT, have pulse, and if not pulse, you have so quickly to short. If EKG is a monomorphic with VT, you must synchronize cardioversion using 100 Joule biphasic. Okay, synchronize cardioversion using 100 Joule biphasic in the monomorphic VT. Okay. Looking at here, the shape of ventricular tachy not similar, and many shapes is named polymorphic VT. If you check of the pulse, your patient not have pulse, the cause polymorphic VT. The patient VT not have pulse, the patient will be unstable and symptom will deteriorate rapidly. Perform defibrillation 200 biphasic, followed by high quality CPR according to advanced cardiac support principle. Okay, เป็น pulseless VT algorithm. Looking at here, VT so many quickly for okay VT not have pulse. Okay, defibrillation. If you not have the defibrillation in the bedside, you must do CPR and the defibrillation to this from here the bedside and to sudden to the defibrillation. Okay, if you not have the defibrillation in this bedside and do CPR to this defibrillation from here, and if the defibrillation in the bedside to defib surgeries. Okay, looking at VT, atrium not retraction, but vertical is traction. Atrium not traction. And S node, SA node, AB node not having. Okay, my is torsade deploy, TDP, torsade deploy. Torsade deploy is looking that is a VT, it's polymorphic VT. Okay, twisting of the point and twisting to the type of monographic VT and send to the between to it magnesium sulfate, the medication is magnesium sulfate to the my patient and to have your know and look at the check your pulse the first time check your pulse not have pulse you to is the treatment that polymorphic VT and do CPR and shock 200 June. Torsade deploy outline look like a party streamer. Okay, if you have looking at the VF, your VF, okay, not have power, CPR, and quickly so to defibrillation 200 June biphasic, very every 1 minute. If you not shock from the in this from not to the defibrillation shock defibrillation the increase of the mortality rate 10%. Okay, every 1 minute not defibrillation 10%. Yes. Okay, looking at here the picture, atrium not contraction, ventricle so the contraction is so fibrillation. Okay, so very dangerous. EEG is very dangerous, the most dangerous EEGs. Okay, I looking at ventricular fibrillation is caused more ectopic focus in ventricle and critical care. The patient immediately to the ECG occur, record ECG to assess and prepare immediately to the fibrillation 200 June biphasic step. And algorithm to the adult tachycardia with pulse algorithm. Okay, looking at those details, synchronized cardioversion, narrow, regular, 50 and 100 June. Narrow regular is the narrow regular is SVT. Narrow regular is 120 AF, atrial fibrillation. Okay, above it 100 June. Okay, biphasic. Y regular is a monomorphic VT. Y irregular is a VT and VF, not synchronized and defibrillation. Okay, adenosine IV dose, first dose 6 milligram rapid IV push flow to the normal standard prostate. And second dose is 12 milligram in free required. But at the center line is a decreased dose, the half of the milligram to a 3 milligram or 6 milligram too. Okay. And Mirorun IV, if you dose the repeated VT occurs, Mirorun. Okay, shock emergency for defibrillation, change for survival from cardiac rate every minute to death rate increase 10% minute to the defibrillation. Algorithm of the cardiac arrest algorithm is very important to this rhythm shock. If the VTVF at shock, okay, this one here look at this algorithm. Number 2, 1 start CPR, given oxygen and attack the monitoring defibrillation. Rhythm shock assess if the yes VT or VF shock. Okay, CPR 2 minutes and rhythm assess shock อีก CPR 2 minutes okay shock epinephrine every 3 or 5 minutes okay consider advanced airway capnograph shock amiodarone shock epinephrine shock amiodarone. Amiodarone is the 300 milligram. So dilution and push slowly in 10 minutes. Okay. And if the symptom is no VTVF, okay, with asystole or PEA, powerlessness, electrical activity, powerlessness, electrical activity. Okay. CPR and looking at his. Okay, VF, powerlessness, electrical activity. You add the CPR and epinephrine every 3 or 5 minutes. Okay, as one can support. Okay, and do if the patient not return spontaneous circulation, use CPR, you as one can support. You remember and recognition to the reversible cause 5S and 5T every time. 5S is the main of the hypoxia, hydrogen ion, hyperkalemia, and hypothermia. 5T is tension pneumothorax, tamponade, cardiac, toxin, thrombosis from pulmonary, or the thrombosis acute from coronary. Okay. Looking at 5H, 5T. Remember and recognition, CPR quality, shockable in emergency and defibrillation, drug therapy as 1 hour for the return submit ROSC, reversible cause 5S and 5T. Very important for note in this very important. And remember recognition in adrenaline. Okay, 1 milligram the 3 or 5 minutes. Amiodarone first dose 300 milligram, second dose 150 milligram. Okay, or lidocaine for its persistent VTVF. Okay, จะเป็น lidocaine. Okay, shockable cycle 2 นะ and non-shockable นะฮะ as soon as the second dose. Okay. The progressive development of cardiovascular disease, risk factor, endothelial dysfunction, atherosclerosis, and the CAD, myocardial infarction, and protection to the congestive heart failure from the remodeling and ventricular dilatation, and pathological to the renin angiotensin system, to the vasoconstriction, heart rate, tachycardia, heart very much heart pumping. And to this, my passion is QLIP class. And it's a QLIP class in the ST elevate MI, looking at the QLIP class, the doctor is QLIP class 1, class 2, class 3, class 1 no clinical heart failure, class 2 is rail arterial and lung S3 gallop elevation GVP, and class 3 pulmonary edema, class 4 cardiac shock, okay, blood pressure hypotension. If you have the QLIP class 1 to 4 is the this is decided to this by patient from the increase of the mortality rate. If you have the class 4 is the mortality rate is increased to 33.67%, okay, and is the QLIP class 1 is 5.826%, okay. QLIP class is to manage to this the clinical side from the prognosis is a death in the patient, okay, and the people my patient is QLIP class not it go to the QLIP class 4, class 3 or class 4. And it to mean do the New York Heart Association, the functional class 1, class 2, class 3, class 4. You have class 1 is normal, class 3 is the symptom, is the have symptom is the ability to exercise and do not strain activity, no symptom, and but you have the rest no symptom. Class 3 is the mildly strain activity, comfortable only at rest, but the class 4 unable to do anything physical activity without discomfort symptom at rest, okay, and New York Heart Association class to the assessment to my patient from the activities. And universal definition classification of heart failure. Definition at risk pre heart failure and S1 heart failure. You looking at it here. Heart failure have the 4 states. State 1 at risk, state A, state B, and state C, and state D. Okay. State A, patient at risk for heart failure, but without current or not have symptom, heart failure without structural cardiac change, Start A is looking like it's normal. Class B, patient without current and no symptom or sign and heart failure evidence once or follow, and structural of heart is change, okay, and no symptom. Class C, patient with current prior symptom, sign heart failure caused by and structural is abnormal, okay. The patient is many symptoms in the ER emergency room is normally to stage C. And what advanced heart failure severe symptom and or sign of heart failure at rest, recurrent hospitalization, okay, and refractory important to guideline directed medical therapy to this, and to want to transplantation or mechanical circulation support or palliative care, okay. A state of heart failure have 4 states: state A, state B, state C, and state D, okay. And classification by ejection fraction. Normally, ejection fraction in the patient is normally is 60 to 70%, but the heart failure is left ventricle ejection fraction lower than 40%. Okay, the name is heart failure reduced EF. Heart failure reduced EF. If the ejection fraction 41 to 49% is heart failure mid-range EF. Okay, and heart failure is EF above 50%, heart failure preserved EF, or heart failure with improved EF. The meaning heart failure is baseline left ventricle ejection fraction lower than 40%, and to treatment and the EF is above it 10 point increase from baseline. Okay, the meaning here to heart failure with improved EF. Okay, definition, state of heart failure, classification by heart failure. Okay, state is four state. Classification is reduced EF, heart failure with range EF, heart failure preserve EF, and heart failure improve EF. Okay. Heart failure normal is the middle. If your heart failure reduced EF is the thin wall of the left ventricle. Heart failure preserve EF is a thick wall of left ventricle. Thick wallness. Okay, thickness wall นะฮะ and stiff muscle นะฮะ and state of heart failure and classification. Okay, a conclusion. If you have the atrial, if the atrial ventricular hypertrophy, looking at here, if you have the right atrial enlargement, the name is the P-pulmonale. P-wave show tall peak, P-wave in 2-3 AVF. Okay, pronounce looking at P-wave. P-wave is the is a tall of peak. P-wave is the P-pulmonale, meaning to the right atrial enlargement. Okay, looking at the picture, P-wave so very long, the P-wave and P-wave amplitude above 210.5 millimeters in lead 2. Physical location from internal external jugular, KVP assessment from the heart failure. If you have the external jugular from the pulmonary hypertension. Okay, position from the check the JVP, jugular vein pressure. Yeah, the normal is 3 centimeters. Right atrial enlargement, P pulmonale. Left atrial enlargement, P mitral. P after looking at M shape, P wave is a P wave Y, M shape, P wave Y. Above 2 to 3, 4 seconds. Okay, P wave Y. Left atrial enlargement. Look at P wave. P wave is a M shape in P mitral. P mitral. Left looking at P wave, M shape, P mitral, meaning left atrial enlargement. The P mitral is from the mitral wall regurgitation. Okay. Left ventricle hypertrophy. Okay, hypertrophy, left ventricle hypertrophy. In this here, normal heart, left ventricle hypertrophy. Okay. The cause of high blood pressure, aortic valve cirrhosis, hypertrophic cardiomyopathy, or athletic training and medical conditional left ventricle to hypertrophy. Technique to the left ventricle hypertrophy from left ventricle hypertrophy. SNV1 plus R in V5 or V6 above or equal 35 millimeter. Okay, S in V1 plus R in V5 or V6. Okay, V1 V5 or V1 V6 above or equal 35 millimeter is the left ventricle hypertrophy. Okay, looking at here, S in V1 plus V5 above, make sure left ventricle hypertrophy above 35 millimeters. Okay, V1 bwok V plus V5 or V6 above 35. Okay, it's a right ventricle hypertrophy. Right ventricle hypertrophy is chronic lung disease, pulmonary hypertension caused tricuspid regurgitation or congenital heart disease. In this, the right ventricle hypertrophy, EKG tall R in V1, deep S wave in V5, V6, tall R in V1. Look at this V1. V1, you know, V1 is a smaller R wave, but looking at right ventricle hypertrophy, recognition nerve V1, its shape is larger and is shoot of V1 show right ventricular hypertrophy, and S V5 V6 not has S wave but have S wave criteria dry ventricular hypertrophy. Okay, to compare its normal EKG for you. V1, okay, and V5, V6, looking that in different right ventricular hypertrophy. Okay, V1, and I know it's V1, I recognition V1 is above of R wave shoot. I know right ventricular hypertrophy. Multiple disciplinary team and holistic team very important to my patient. Dietitian, heart failure specialist, cardio surgeon, cardio specialist, palliative care, primary care, heart failure nurse, pharmacy, social worker, PT, physical therapist, so very important, and the multidisciplinary team to improve quality of life. You my patient from event based. Take care for your heart as if it were our one doctor, pharmacist, physiotherapist, nurse case manager, or advanced practice nurse, nutrition, okay, and patient and caregiver to cover it. Do the take care for your heart. And go to the guideline primary prevention, blood sugar, LDL, blood pressure, obesity, diet and exercise, quiet smoking, risk factor modification. And role of nurse, especially in CAD and heart failure clinic. Symptom management for CAD, self-management perspective for CAD, nutrition and CAD, medication, promote cardiac rehabilitation, manage of CAD, family community care for CAD, intervention and innovation for CAD and heart failure patient, palliative care of CAD and heart failure patient is the role of nurse specialist in CAD to know in under competency and healthcare accreditation institute public organization in the coronary artery disease and acute coronary syndrome. Dimension of the quality, accessibility, easy access, no long waiting, equality. Continuity of service, simple, seamless, and continuity of care, effectiveness and appropriateness to modern skill, interest, and curable. Efficiency, value of for money, good value, and economical. Patient people-centeredness, be attentive, keep time, listen, speak clearly, speak clearly, take care of the word person, take care of as if they were a person. Population focus, no matter what is it, it can be treated. And safety, safe and have a good quality of life. Okay, and wow, it's 30, so time for completely. Okay, thank you for your attention, every person. If you have the question, Mr. Farmerworthy.
Okay. Thank you very much, Mr. Winit, for your amazing presentation. Please giving a big applause for our the last keynote speakers. Okay. Okay, this is really the topic we discussed today was really interesting actually, Mr. Winit. So okay, we are going to the another sessions is the question and answer sections. So for all the participants, if you have any question, please just
thank you so much. Powerful presentation. Thank you so much.
okay. Okay.
If you have any question from this joiners to in the web seminar, okay, to the message for me, and in this international web seminar is the message for me, okay, and try to answer the question.
Oke, baik. Kita lanjut kepada sesi tanya jawab. Apabila ada yang ingin bertanya, dipersilahkan. So if there's any questions,
yes.
just please. We can you can put the questions on the chat box, or maybe if you wanted to ask directly to our keynote speakers, just clicking the reactions.
Mr. Famwati, the Drew Kinlan, thank you for Mr. Vinit for your presentation. It's very clear, especially about it to second degree
Second degree affect
in the
block
block
and third
and
degree
third degree
affect block.
block. I confused before, but now it's really understanding. Okay, I not to presentation, but I have the PowerPoint to you. Yeah, this PowerPoint to
Okay.
you because of the 1 hour and though it's normally is a presentation from the EKG basic to advanced EKG interpretation in Thailand. It's a 6 hour in Thailand basic to, and it's a coverage is a wonderful, so very difficult to read. And
Okay.
and looking at the professor in the 3-person in the morning, you have and your increase of the PowerPoint to you to many person to the learning by doing. Okay.
Okay, actually we give all the presentations to all the participants later. So after this, all the participants will have your presentations as personally as well. Okay, so okay, maybe Mr. Winnie, because this is
not having the question, Mr. From Mati, you have your question for me.
But actually this is because there is no further questions. I think I will conclude this our Q&A section for today. So yeah, my heartfelt thanks to you, Mr. Winnie Longlaren, for this amazing presentation, for graciously sharing your exceptional expertise and insight with us today. So I look forward to our next encounter, that at the future scientific gathering, so we can meet each other also. Okay, thank you very much, Mr. Winit, for your amazing presentation. So before I close this seminar, I will let you to maybe give some take-home message for our all the participants. So the time is yours.
Learning by doing and learning so very time to the in the clinic and to the knowledge sharing and is the reading and learning by doing from my passion. You have to good at from this EKG interpretation. If you are looking at a web seminar and you not do reading EKG, you have so very not at the technique in it here. If you have learning to from my passion, you learn more and you good at and so excellent from clinic and excellent to this coverage from the ECG interpretation continues.
Okay, thank you very much, Mr. Winit, for your time. And this is really an honor for me to lead your seminar today. And thank you very much, and see you later in another time. Thank you very much.
ขอบคุณครับ สวัสดีครับ
Kapun. Baik, teman-teman semua, seluruh peserta seminar International Webinar Advanced Electrocardiogram Interpretations hari ini, maka dengan berakhirnya sesi Q&A di sesi seminar yang keempat bersama Mr. Winit Longlaren barusan, maka menutup pula rangkaian seminar kita pada hari ini. Sesuai dengan janji saya, di mana kita di sini dari Cito Organizer, selain mengadakan seminar, kita juga ada door prize. Saya ucapkan selamat kepada peserta-peserta teraktif. Ya, di sini saya akan umumkan pemenang dari door prize kita. Selamat kepada pemilik akun atas nama Rukialun Bekasi Kota. Yang kedua, selamat kepada pemilik akun atas nama Muhammad Ulil Amri. Dan yang ketiga, selamat kepada pemilik akun Eka Suarida AMK. Ya, saya ucapkan selamat kepada seluruh peserta yang mendapatkan door prize. Ya, seluruh peserta yang berhasil mendapatkan door prize berhak untuk mendapatkan saldo e-wallet sejumlah Rp50.000 untuk masing-masing pemenang. Dipersilakan nanti untuk teman-teman yang tadi namanya saya sebutkan bisa menghubungi aku admin @Cito Organizer. Baiklah, terima kasih banyak teman-teman semua yang masih siap sedia menyimak seminar kita dari awal pagi tadi sampai siang hari ini. Saya Faisal Azhari memohon maaf apabila dalam memimpinnya acara webinar kita pada hari ini masih banyak sekali kekurangan dari diri saya. Dan saya mengucapkan terima kasih banyak kepada teman-teman semua yang pastinya masih tetap semangat untuk tetap menimba ilmu di hari weekend kita pada hari ini. Ya, baiklah. Untuk itu saya akhiri acara seminar kita pada hari ini. Terima kasih banyak kepada seluruh pemateri yang sudah hadir hari ini dan juga seluruh peserta yang sudah hadir hari ini. Saya mohon pamit undur diri. Billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.